with a very strong academic training and clinical experience in child health and critical care. She completed her MBBS in 2020 from Bakura Samilani Medical College under the West Bengal University of Health Sciences, and went on to pursue her MD in pediatric medicine from the prestigious Arjikar Medical College and Hospital, Kolkata. A basic and advanced neonatal resuscitation program provider under the first Golden Minute project of the Indian Academy of Pediatrics. She reflects her specialized skills in newborn resuscitation and neonatal emergency care. She's also an ALS and a BLS provider certified under the NELS Skills Lab at Arjikar Medical College, highlighting her proficiency in the advanced life support and critical care management. Dr. Esha has also actively contributed to academic medicine. She has presented posters and research papers at important scientific forums, including the East Zone Pediatric Critical Care Conference and the West Bengal Annual GastroCon. She has further enriched her academic journey by participating in multiple CME programs and national conferences, including the West Bengal State NEO COCon and the 5th National CME of Pediatric Neurology held in Kolkata in 2025. Her clinical interests span pediatric critical care, neonatology, and evidence-based pediatric practice, and she's deeply committed to continuous learning and knowledge sharing within the medical community. And being someone who has been not just a friend and or whatever you can call for her for such a long while, I can assure you that this session is going to be a masterpiece. I can assure you that this is going to be such a rich session where you will be getting in the very nitty-gritties of pediatric and neonatal resuscitation, both as BLS and ACLS providers. So yeah, welcome to this journey aboard, and I would love to welcome Dr. Esha to take over. So please, Dr. Esha, the stage is all yours.
Yeah, thank you so much. Can I just view the screen once? The screen is, the presentation is visible to me yet.
Yes.
So while the technical things await, hi everyone, welcome to this session. I am fairly new to this online teaching module, but I am an eager learner, and I hope that I can impart some clarity regarding some things which are fairly basic, but they actually can save lives because intervention within a correct time window is very, very, very critical. And as I am a pediatrician, and hopefully in few days, super specialist also, because I am planning to take up SS also, most probably in either NICU or PICU fields. So I am of the opinion, and I have obtained this training that uh, stitch in time saves nine, even though it's a surgical thing that people have said. But this is something I truly follow, that intervention or action done in a correct time is worth your effort. And I hope that my session helps you understand what we come across in pediatrics and how we can manage emergencies. Especially the BLS part, I must say, that is something every one of us should know. And I would like every one of you to go and do these BLS programs, because those are very, very, very needful for life-saving things in outside hospital scenarios. So, yeah. Okay. I am still not.
Yeah, you'll be able to see the screen now. You'll be able to see it.
Yeah. Okay. It's done. Yes, thank you so much, Dr. Jim again, and thank you, my dear brother Navoni, my batchmate, my friend since 10 years and more and counting. So I think we'll start, and in between we will have some interesting pauses and we will continue. Okay, so yeah, so please, I am going to go for the first slide. Okay, so the first thing I must tell you all is what I am hoping that we are going to achieve through this session. So, no, the first, just the previous one, please, Dr. Rimshan. Thank you. Yeah, thank you. Okay, so in this sequence, maybe our sequence might muddle a bit in between, but we are firstly going to know and think that how the child arrests, like apart from any adult who can collapse and go through any sort of like a life-threatening event, we are going to first go for the BLS sequence, like basic life support sequence. To understand it very simply, is that that's something we come across very filmy way, right? In a airplane, sometimes an air hostess shouts out, is there anyone who's a doctor? So in that scenario, what you need to know and learn is the BLS sequence. Okay. I have tried to incorporate the basics in the slides, but as I go through slides, I might add some nuances or some different things which I have come across in my very limited but okay ongoing experience. So then after that, we're going for PALS. PALS is an American terminology. Since I am a member of the Indian Academy of Pediatrics, so the PALS algorithm is adapted, and I will be speaking to you about the Indianized IAP ALS algorithms, but it's fairly simple and similar to PALS. And in the PALS only, we're going to have some little bit of discussions about the shockable rhythms, because there are some usually uh, confusions regarding pulse electrical activities and PSVT and whatnot and things. I'll try to make it simple as much as possible. And then some things that I'll try to explain with some real life experiences that I have come across in my PICU days. So, Dr. Rinjim, can I move on to the next slide, please? Okay, so firstly, uh, if you can look at the cardiac arrest epidemiology. So, firstly, in pediatrics, one thing is very much important, even in neonatology, even though neonates are just 20 days people, but they are a completely different physiology from us and even from children. But in neonate and in pediatrics, one thing is sometimes of paramount importance, that is the respiratory thing is very much more important sometimes than the cardiac thing. See, in since we are all doctors in our MBBS days, some things we have learned, right? Always start with A, B, C, D, E, resuscitate with C, A, B. All this A, B, C, D, E first or C, A, B first is something a confusion, right? So in case of pediatrics, one thing you have to learn and remember, even though you are going to, as a BLS provider, you are going to start with compression, airway, and breathing, or cardiac things and airway and breathing, CAB, in case of an arrest. But the reason of the arrest is most often a respiratory underlying cause, because children are fairly uncommon to have arrhythmias, although they can have long QT syndromes and many things, but those are fairly rare, and rare is rare for a reason, as we all know. So, firstly, there is so many things like airway obstruction. Often we see this, right? This Heimlich maneuver and backslap and those things that it's not in the scope of this webinar to teach. That's why I am emphasizing that all of you please kindly certify yourselves in BLS, because those things are very important to learn. That often an upper airway obstruction can lead to a life-threatening arrest. And apart from that, there are these bradycardic or apneic episodes that children seem to be having time and time again. And any respiratory thing, like it's an upper airway obstruction or a lower airway lung parenchyma thing, like pneumonia, that can eventually, if not corrected, end up in a cardiac arrest. Although those things are not usually causes of out of hospital arrest, but as you can see from this lovely infographic, that this respiratory failure is usually much more important in children. And but in case of BLS, in the scope of BLS, we are going to put ourselves in the midst of and just out of hospital scenario, and we are going to consider all situations, like we are in a field or we are in a train or we are in a crowded bus and someone collapses. Be it a child or adult, it's fairly simple to extrapolate it to the adults also. Just some basic things are changing, but the baseline remains the same, that we go for CAB. So that is that if we learn how to give CPR, and that is high quality CPR, then that is very easy. That till a team who knows about this advanced care of resuscitation or that is available, they can come and take over from us. But in those few minutes, actually, those few efforts of compression or even giving a rescue breath on those things can actually save lives. So please next slide. Yes. So as I said, this is the pathophysiology behind it, right? The firstly, I am going to something I'm not at all comfortable in. Look at adults. Usually the adults are suffering from cardiac arrests. Most often they are due to arrhythmias. So those arrhythmias can be of many kind, and also often we can see like there are lifestyle diseases. So underlying lifestyle diseases or untreated, uncontrolled hypertension, diabetes, those things can sometimes lead to a sudden cardiac arrest. And that is a usually there is also a very much shockable rhythm. So now I think in malls, I think you can, when you visit a mall, from now on, I'd like you all to just look around and ask if you can, if you have this in mind, that where is the AED? Okay, automatic external defibrillator. So you ask them that where is that? So because if someone collapses in front of you in a mall and you know where is that AED, you can actually literally perform a miracle and save a life. So, because in adults, mostly if they suffer from a collapse due to a cardiac arrest, and that is often due to a arrhythmia, an arrhythmia which is a shockable rhythm. Okay, so we will try to delve into shockable and non-shockable rhythms if time permits. But now switching to my comfort zone, pediatrics. So in pediatrics, we have seen it's a no, the previous one, please, Dr. Dim. Yeah, thanks. In pediatrics, we have seen that respiratory causes are mostly the underlying thing. So respiratory failure is actually the underlying villain in everything, because hypoxia is a stimulant or is a deterrent which leads to bradycardia. So that bradycardia actually ends up in a collapse and shock. And one more thing, that children are usually able to maintain BP, or rather, we say it like this: BP is the last parameter to fall. Usually, the children who are in shock, BP is very difficult to just comment from a BP whether the child is in shock or not. So we look at other parameters. Okay, so now let's go for the next step. Next slide. Yes. So we are looking at this chain of survival. Okay, so if you guys are going for a BLS training, this is a very favorite question of them. And if you just are okay with it and conversant in this chain of survival, then you immediately earn a brownie point from them. Okay, I very recently did this training, and so they are very emphasizing on this. So I am going to do that also. Firstly, you try to prevent it. Like like those things are written in toy packets, right? Choke hazard, or you don't give small particles to children. So you prevent things like upper airway obstruction, or if the child is having a respiratory distress or something, you immediately refer to a hospital and you intervene. Secondly, comes the mode of AED, like early intervention and early recognition. So, call for help, as you will see, is the first step in all arrest scenarios, mostly in all the algorithms. So, firstly, you have to notice, and after you are ensured that the scene is safe. Okay, Dr. Aishwarya, other signs to detect apart, just give me one sec, I clarify. Other signs to detect apart from BP is capillary refill time and heart rate. Those things actually help us understand. I'll try to elaborate this again as we go through PALS. In PALS, we will identify in circulation shock and stuff. Okay. Okay, we will take questions at last. Sure. Okay, so continuing on, early recognition and call for help. That's why we are going for the AED. If you know the location of AED, or if you know someone who knows where the AED is, because it's an out of hospital scenario, so then they can immediately activate the emergency response. Like I think all of us have seen in every like TV series or movie in which they call up 911, right? In our country, there are some emergency numbers which are different for each state. So in my state, it's actually 112, if I'm not wrong. But in your state, it might be different. So you must also know as a doctor that what is that emergency number, and you can then call them up and they will respond. Okay, they will respond, like they will come and they will take the arrest victim or arrest survivor to the hospital. That has happened. We have seen that. Okay, so after you call for help and activate the emergency response, you as a ALS provider or BLS provider start CPR, and they have shown a mask ventilation, but in BLS scenarios we give a mouth-to-mouth breathing. Okay, so after that, if there is rescue and or there is improved thing, then we go for recovery and post-arrest care. So next slide, please. Okay, so these causes are actually something we will come back to, but this is one thing I must emphasize upon again, that pediatric cardiac arrest, usually we have, this is a statistic actually, the algorithm does not always take into account the stat, but most of the rhythms in pediatric cardiac arrests are seen to be non-shockable. So these things, even if you just like a filmy manner, be very enthusiastic and give the shock, so that nothing will work. But some rhythms are there which are pulseless VT or ventricular fibrillation or even sometimes supraventricular tachycardia, which are shockable. Okay, so that is why something our sir PICU in charge has told us that whenever possible, uh, get the defibrillator machine ready and by the side of the patient. No patient should die without uh, at least having some use of the machine. But I know it's not always possible for all of us. But the AED thing comes in handy very much because the AED is designed for a non-medical person also. So if you attach those pads and stuff, the machine is very rudimentary and self-explanatory. Okay, if you see it, it's very simple. There are two pads, and one is attached to the shoulder and one is attached to the apex. Okay, cardiac apex. And in pediatric, there are usually other pads like small size pads, but the same pads, if the child is large enough, you can use, or you can use the pads front and back, like in front of heart and in between the scapulas. The only thing that you must keep in mind while applying the AED is that you should not overlap those pads. Something to keep in mind. Okay, so after you just put those pads and switch on the AED machine, we'll come to this again when we go through the algorithm. But once you switch on this machine, the machine does the job for you. It will analyze the rhythm during the time. It will ask you to stop compressions, and the machine will analyze the whether the rhythm is shockable or not. And if it's shockable, it will say that the rhythm is shockable. I'm going to provide shock. Then it will alert you. You will then clear away from the patient, and after the shock you will again resume the compressions. So that therein lies my point of being conversant with the AED and defibrillator. Yeah, the joule is different, I'll tell you all. Okay.
Okay,
uh,
just a minute. Just give me a minute. I think Rimjim is facing a little temporary lag. Rimjim, I request you to once shut this and yeah, and represent it again. Just give me 15 seconds. In the meanwhile, we can take up doubts, whatever has been taken up till then. We can see the chat box for the doubts.
okay, so go through the doubts. The one doctor asked me about the shock thing, right? So the shock, usually I am someone who has come across really, really bad septic shock in my 3 years of residency. So septic shock in children is something that rings huge alarm bells for me. So, but one thing I have seen that there is in children a very much tendency to go into uncompensated shock after a certain point of time. And that certain point of time is very, very impossible to determine. So you just look at the tachycardia and the capillary refill time and the periphery to core temperature difference. Like we touch the patient's abdomen and look at the patient's uh, yeah. So okay. Please next slide. Yeah. Very well. Well done. Okay. I'm going from this only. No problem. Okay. So this slide is visible to all, right? Can you just zoom the slide in a bit, please, Dr. Rimchan? Okay. So coming to this algorithm, just let me conclude about the shock thing. So that flash capillary refill, if you know how to look at it, I'll elaborate again. That is a alarming thing. Cold peripheries, another alarming thing, and tachycardia, which is not explainable to the other comorbid things. So that is also alarming thing. And looking at the overall picture, we can actually think about a shock. And I'll go for that. Okay, I'll take the doubts again. There's no problem. You can ask me. Okay, so looking at BLS. BLS means you are outside. That is why the first thing is verify the scene safety. Okay, so you have to suppose you are in a earthquake prone zone, like where you have gone to visit Darjeeling, like we Bengalis do, and in the middle of a stroll through mall, you have seen a suddenly collapse of someone in front of you. But then you are also feeling the earthquakes. So in that point of time, you are not able to intervene because firstly, in that place, you are also in danger, right? So in case of mass casualty events, also this scene safety is important. And one more thing, that is, you have to look for a flat surface which is fairly clear and you have a clear view of the patient. So then you check for responsiveness. Okay. Also, scene safety means you have to look for hostilities. I think being a doctor in India, we don't have to emphasize this much more. It is very sad that we have to look for it, but scene safety also means hostile people. Okay, let's not go there. So then you check for responsiveness. How? You ask someone who knows their name, or you just tap on their shoulders very firmly and ask, "Hey, are you okay? Are you okay?" Like that. If they don't respond, then you immediately shout nearby for help. Somebody please help me. And if you can activate the emergency response system. If you know the number, right? Otherwise, you can ask someone else also. Then this is BLS. This is very basic. This is outside the hospital. So you are going to do very basic things. First thing you are going to do after noticing the collapse, you're going to look whether the person is breathing or not. This is for a child or an adult. This is the bloody same thing. You are going to look whether there is breathing or not. And if there is some breathing you are noticing, you have to see whether this is a gasping pattern of breathing or not. Okay. And after this, while you are looking for breathing also, you are going to put your thumb in the carotid artery region and check for the central carotid pulse. This is same for everyone. In case of pediatric patients, also check for the carotid pulse only if you are not able to locate the carotid pulse because the children sometimes can have chubby necks and short necks. Then you can go for the brachial pulse or femoral pulse because those are central pulses and you are usually fairly easy to locate. So the how do we locate the carotid pulse? It's very easy. After uh, usually as pediatricians, we are taught that from the midline you go to the lateral side and you go for just midpoint between the two heads of the sternocleidomastoid muscle, right? And same on each side. So on any side, you check for the carotid pulse just for 10 seconds because if you are outside, every second counts. And you check for the pulse. Now there can be usually two type of scenarios, right? First kind of scenario is the patient is breathing. The patient might be unconscious, but the patient is still breathing and you are feeling the pulse. Fine, very good. You are saved in a manner. You just reassure people, ask them to clear the scene and ask them to expedite the rescue process. And you have to monitor. As a BLS provider, you have to monitor until someone comes and takes over from you as an emergency response process. But now there can be two very, very, very important scenarios. We are coming to the right side thing first. Okay. The right side thing is there is no normal breathing, but the pulse is felt. Okay, so the patient has circulation. That is okay. Patient circulation is fine right now, but we are going to improve the ventilation now. So we are going to provide the rescue breath. How do we provide the rescue breath? It's usually it's taught in BLS that you give mouth to mouth breathing only, or if someone are BLS ALS providers, they can carry a sort of a mask which has a uh, device which can like sort of a straw attached to a big mask. Okay, for our ambu bags, we use those masks, right? You can carry one such mask also with you. And you just put the mask on the child's face, cover it adequately, and just give a mouth to mouth breathing every 2 to 3 seconds. Like you give a breath, just inhale for some time and give your tidal volume, not a huge amount of breathing or perform those spirometries that is not needed. You just give your normal tidal volume. And then you give this for about 1 minute. After that, you are going to check for heart rate again. Okay. So heart rate, if this is still less than 60, and you can see the patient is pale, the lying person who is lying, the baby who is lying is pale, and you are not having any peripheral pulse. So this is a situation you are going to start CPR. But if the heart rate is more than 60 and there is no sign of poor perfusion, then you are going to continue rescue breathing. Like you are going to give the rescue breaths every 2 to 3 seconds, and you are going to reassess every 2 minutes. Okay. Reassess of pulse for 2 minutes. After 2 minutes is a standard thing. It's standardized throughout all these algorithms. So in between your pulse checks, if any time you find that for 10 seconds you check the pulse, multiply the number by 6 and find whether that is less than or more than 60. If it is more than 60, fine, you continue your rescue breath till the help arrives. If it's less than 60 of any point, you again initially shift to the arrest algorithm, which is the CPR algorithm. So CPR algorithm is 30 compression and 2 breaths. Okay. So one thing is there, if you are a single rescuer, this is a new addition. Uh, I think, okay. Yeah, thank you, Dr. Dimson. Yes. So if you are the sole witness, then if you have noticed the child has collapsed in front of you, like you saw a child who was playing. Okay, this is something I am telling. This is quite specific to pediatrics, but it can be extrapolated somehow. But in case of pediatrics, this is something we were taught that if you witness the collapse, like a playing child suddenly collapses, then that is usually not a respiratory cause. So then activating emergency response and getting the AED takes precedence. Okay. So then you are going to go activate the response and then come back and go for CPR. So now what I was telling that in case of one rescuer, you are going to do 30 is to 2. Like you are going to give 1, 2, 3, 4, 5, 6. Exactly this rhythm you have to follow. And again, it's beyond the scope of this lecture that I'm going to show that how to properly give the CPR. But one thing you must remember that you have to lock your elbows. All the movement that should come from your shoulders, you should just kneel in front of the person and just lock your hands, lock your elbows into a fixed position and then start moving. Okay. And in case of a child, you can just give a one hand CPR also sometimes. That in case of infant, actually, we do not in case of a child. In case of child, in case of children or chubby babies, also sometimes we have given both handed CPRs. There is no issue in that. Okay, so first rescuer 30 is to 2. If you have a person who's come to help you, then that second person will come and then that person will take over ventilation and you'll have to give 15 is to 2, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, up to 15 you go. Then that person will give 2 mouth to mouth breaths, or if you have your mask with you, they will give that. And like this you go for about 2 minutes. Okay, about 2 minutes you go like this, and then, as I said, if the AED is attached, then the AED will ask you itself that the pulse check is necessary, and then the AED will check rhythm. See, you can see it's very well illustrated in the algorithm only. This shockable or not. Okay, if it is shockable, the AED will prompt you that analysis done, shockable rhythm, suppose. Okay, then you will clear and then the machine will administer the shock. What is very important, immediately after the shock is delivered, this alert prompts, some speaker or kind of thing will come. Then like in speaker alert, something like this will come, shock delivered. Okay, the flashing lights will go off in the AED and then you will immediately resume the CPR for 2 minutes before propelled for another rhythm check by the AED. After the shockable rhythm, the shock has been delivered, you are not to stop CPR. That is very important. Okay. If you are interested, I'll explain later only. But it's very important, very paramount that you immediately resume the CPR for 2 minutes. So it's fairly simple from now on that every 2 minutes, the AED will analyze the rhythm and ask you to deliver shock or not. So after that, usually if after delivering the shock in the pulse check, we find that the heart rate is more than 60, then again we gradually stop the CPR and wait for ALS, we monitor. And now, most important is the right side. Again, Dr. Timson, can you please zoom on the corner right of the, yes, that part, yes. Yes, that part is very important because corner right, please. Just a bit right. Yes, thank you so much. Okay. So if the alert comes, the rhythm is not shockable, then you are going to resume CPR immediately for 2 minutes because we can't stop CPR. And if you are fatigued, then the two-person is going to coordinate. For 2 minutes you give, then you move to the ventilation part, your partner comes and this 30 is to 2 cycles, whichever happens, and in every 2 minutes during the pulse check. Okay, you have to, like, you all have to be competent enough to do CPR for 2 minutes straight. And I must tell you, it's no small feat. It's very, very taxing physically also. Okay, so this thing goes on both sides. Like if you find a shockable rhythm during any point of the 2 minute cycles, the AED will prompt you and you are going to provide the shock and then immediately continue the CPR. Like this, usually until the ALS providers comes or you achieve a pulse more than 60, then you monitor the patients and post-resuscitation care goes on. Okay, next slide, please. Um, Next one, please. Yes. Okay, so this is no zoom in is required, Dr. Rimsham. Yeah, this is actually the same slide. If you see, this is just coming from two or more rescuers. Like you are a team of BLS, like or they take like exam in the BLS exam scenario. You are two people. One is for ventilation, another is for chest compression, right? For each cycle. So if you are two people, those things like activating AED things are usually not something you have to go and do. It's very simple that usually all the things are same as I told. Only the emergency response activation part that was in case of a single rescue that was added, that is different. And also you start doing 30 is to 2 if you are alone. Again, another person comes, you go for 15 is to 2. So this compression rhythm is something that is very different from adults. Okay, now some questions that arises that suppose you are having a 12-year-old child who is like 15 kgs. Okay, very malnourished. Would you go for a child rhythm? The answer is if you see a malnourished child, but you can see any sort of sign of external sign of puberty in them, like appearance of chest hair, or in a case of a girl, any signs of development of the mammary glands. If you see, then you will treat them as adults and go for 15 is to 2. Uh, sorry, go for 30 is to 2. But if you see that the child doesn't have any sign of puberty, whatever the age of the child is, you usually go for the 15 is to 2 rescue sequence. Okay, breathing and compression. Okay, Dr. Jameson, next please. Okay, so I think we need to zoom out a bit, Dr. Rimjim. Uh, no, okay, okay, it's fine, it's fine, it's fine, it's fine, it's fine, it's fine. Just go back. Yeah, okay. So if you see the beautiful infographic, I will thank Navani so much for all this. That some tick boxes, that is immediate response by first rescuer. As I told you, have to see safety and then shout for help. You are going to focus on the airway breathing and circulation. You are going to start CPR early and you are going to defibrillate if needed. If defibrillation means using the AED in this scenario. Okay. Now this two finger technique in infants or the two thumb technique in two finger technique in infants is something I am not very fond of, and this is something our teachers, like our pediatric medicine teachers, are told not to do. But it's fairly simple. You just like a gun, you just do this and keep this hand just over the sternum of the patient and just through these two fingers. I think my fingers are visible. This motion has to be done again. Your wrist joint onwards, there should not be any more movement. Like these joints should not move from the wrist to the patient's chest directly. This should come. Okay. And two thumb technique, I think all of us know in neonates, we encircle the chest and like this. I think I'm not able to show, but we might have some GIFs for you to show. Okay, so one more thing that I think needs emphasization here, that is what are the parameters that can define a high quality CPR. Firstly, this rate 100 to 120 per minute, like this I told, na 1, 2, 3, 4. You have to coordinate this. After one, within one, and you have to go for 1/3 diameter of the chest. And very important, you need to allow the recoil, because recoil means filling of the heart with blood. Then in the next sequence, once again you push, that blood flows out. So recoil elevation is very important. And next, you have to minimize interruptions, as we have told. In case of a single rescuer, you only have to provide rescue breathing, and you only have to provide like compressions. Then you go for 30s to 2. In no point whatsoever you switch from 30s to 2. You give 30 like compressions, and you give 2 rescue breaths. Again 30 compression, again 2 rescue breaths. In case of 2 rescuers, you go with 15 is to 2, 15 compression, 2 rescue breaths. Okay, like this you go on. Okay, next slide, please, Dr. Dimji. Okay, so one thing only, I think, in this, I think I have elaborated all things previously only, just to reiterate. Ensure scene safety means whether it's a flat surface or not, whether there is any chance of buildings falling upon you or not. Okay, assess environment, any hostilities there or not, or any environmental like emergencies are there or not, whether you are in a polytrauma situation or in a mass casualty. In all those events, the environment and the scene safety takes paramount importance. And I think all of us know now in those situations, this trauma trials thing happens, like the red, green, yellow, and black, those tagging of trials happens. So again, beyond scope of this presentation. And universal precautions means usually you have to, because you have to give those mouth-to-mouth breathing, it's better if you have a mask with you. But there is some research that providing a mouth-to-mouth breathing is not really that much of a risk for any kind of transmission. I also asked this in my training. So that instructors told me that, see, I can understand that everyone culturally might not be acceptable also to give a mouth to mouth, but you always carry some piece of like fine cloth with you, right? A handkerchief or something. You just put it over the patient's mouth and then give. But it's very important that you seal your mouth and their mouth. Okay, it's very important. Like we use the mask. Now I'll show the C&E technique. That's very important. I think all of us have seen it. So those things, Dr. Novril, I think you are some, yeah. Okay, thanks, Novril. Okay,
Sorry.
so no, it's okay, fine only. So these things are important, and mouth-to-mouth breathing is very much important because often we are alone. But as I am telling, that sealing your mouth to the patient's mouth is very important, not the person who has collapsed. Because you are a doctor at this point, you have the ability to save lives. And also, when we have our equipments with us, like the mask and the bag, we are very, like, I am a pediatrician, okay? So I am very, you can say, uh, very much icky about not having a proper seal on the mask. See, in NRP, all the things happens properly if you are able to provide a proper BMV, bag mask ventilation. You might not also need to go to chest compressions. So that is the thing. Sealing the mouth, that is very important. Or the equipment with the patient's face like this seal should be maintained. Okay, Dr. Rimjin, next slide, please. Okay, I think we covered this, right? Tapping on the patient's shoulder. It's very important you tap on their shoulders firmly. If you know their name, you call out their name and observe the breathing and call for help. Next slide, please. Yes, I think I explained all of this in the algorithm only. I'm moving forward, Dr. Rinsu. Yes, this is a summary. When are we starting the CPR? As we saw, after witnessing a collapse, if there is no pulse, there is less than 60 pulse with very little perfusion, then we are going to jump into compressions. Okay, next. I think again I covered high quality CPR means all those things. Yes, I think this is also covered. And please now play this. So this is the two finger. As you can see, they have kept the two fingers very straight. Okay. Actually, this is a bit of faulty technique. Yeah, this one is right only. The later one was right. The first one had some folding in the hands. Okay. So next, please. Yes. So I think done. Yes. Airway management, I'm going to tell that this usually you don't do in BLS. If only you are doing this when, if you, okay, something I should have covered. During providing the rescue breaths, one thing you have to see whether there is chest rise or not. Same as we go for in all our those NRP things from MBBS, some algorithms that we really hate. But as a person who lives by and swears by those algorithms right now, I must tell you, algorithms make your lives very easy if it is there. So if you see there is no chest rise, then you are going to do the head tilt and chin lift. It's a airway maneuver, as we all know, right? A very basic airway maneuver. So I think it's beyond the scope of this, but it's a PALS, and mostly it's a ATLS protocol where they teach you those things. Because head tilt and chin lift is nothing. You just go for this. Make the patient lie down in a sniffing position, as basic as NRT. Chin lift is nothing. You put your finger behind the jaw and this. Okay, like I think I can show you, but it's better if I show you on a mannequin. And jaw thrust is done in a trauma. It's something I can't really show you. I need another person to show. But if you are suspecting there is some trauma to the C spine, cervical spine, you can't do a chin lift or head tilt. That will further dislocate the spine and you will immediately be endangering the life of the patient. And BMV, as I told you, ensure the seal, look for the chest rise and the CNE technique. We will have I think, GIF regarding that. Okay, so next, please. Okay, so escalation of airway is those things only. Positioning of airway means those maneuvers. You can look at the GIF. This is a neonate although, but the basic thing is same. See, they are going to do the C and E. Watch the video once and I'll show. Okay, one thing they have not done properly, I must say. I'm a bit perfectionist in this regard. Sorry for that. But one thing you must do while you are applying the mask, you apply it on the chin, then over the nose. Like this, you put the mask. That ensured the seal very well in case of any patient. Okay. And all those airway sizes masks are there. Like this is a neonate, this is looking like a term unit. So this will require a one mask. If it's a very preterm unit, it will require a small zero mask. So it you put like this over chin, then mouth, then nose, like this you put. And then you are going to do this. One hand, you are going to hold your mask like a C. And the other three of fingers of yours will hold the patient's chin like and jaw like this. So the CNE is very easily demonstrable than describable. Okay, you can demonstrate it fairly easy. So again, beyond scope of me. So bear with me for a moment. Okay, so BMV, as I told you, that sequence is more important, 2 to 3 rescue breaths. So BMV comes importance where? See, you have seen a collapse, the pulse is all right, but the breathing pattern is bad. But one more thing you must remember, if anywhere you see a gasping pattern of breathing, there you also don't go for a positive pressure ventilation. There also you start CPR. Don't go for a rescue breath. A gasping breath is a bad sign. You straight on go to a CPR algorithm. Supraglottic airway means usually the LMS, laryngeal mask airways. I think every one of us has seen it. I have not practically used it because in my residency I have learned to intubate fairly well, so I'm much more comfortable with intubation. So that is our next advanced airway management. Okay, next please. Yeah. So this is something I think we will again come across in PALS or Advanced Life Support. But this is something that is not in the scope of BLS, because in BLS, the AED delivers your shocks. The AED is not going to tell you the joules. Usually, they give the 2 joule per kg. Okay, they approximately do that. But this is, I have written something which is purely pediatric. In adult, I think the dose is, I think Navunil can just unmute himself and tell me, because I have really forgotten. I think it's 100 joule or maximum 400 joules it can be given, right? Please, Navunil, can you speak up once and tell us if you remember? Okay, Dr. Navunil is somehow not there, but this
Sorry,
is
sorry,
this
I was
thing.
on mute. Sorry, I was on mute. Yes.
Yeah,
So
I was
as
asking you
Dr.
about the adult dose because I
Yes,
have forgotten
yes.
every adult things.
Yes, yes. So
I'm
for
sorry.
adults, basically, when we are using a biphasic defibrillator, I mean the one that we most commonly use, the first
Yes,
shock is around 120 to 200 joules. Okay,
yes.
and
That I okay. I was fairly right
subsequent
then.
shocks,
Yeah.
yes, and the subsequent shocks will be usually around 200 joules. We have to maintain a higher amount of joule frequency in the subsequent shocks. However, the older machines, which are historically called the monophasic defibrillator, uh,
Mm-hmm.
these are going to develop around, I mean, give around 360 joules. So the current ones that we use is around 120 to 200
Yeah,
joules,
I
and
was
200
taught this
joules is usually
100 only, and the
yeah.
highest is
It's 120.
400, right?
Yes, you can reach to a highest amount of 400,
Or
but then
400.
400
Yeah.
practically we don't give. I mean, it is
Never we
baseless.
give.
Yeah, it's
Exactly. We
baseless.
never give, but just some theoretical things.
Yes,
Okay, so
absolutely.
this
Very true.
Mactima, okay, thanks, Navul, so much. Okay, one more doubt. Am I visible to you guys? Because I was doing so many gestures. Are those visible? Because my screen is not visible whether I am visible or not. Uh, if anyone can say.
Yes, you're visible.
Okay, thank
You are
you,
not just
Christina. So,
visible, Dr. Esha. Every maneuver that you are showing is perfectly visible.
okay, okay. So all those animated things are coming to work. Okay, thank you, Dr. Rimjin. So next slide, please. Yes. These questions I'll take up in the end because I'm right now, yes, going for PALS. PALS is something that is going to go for that this advanced life support. That means only one big thing is different, that right now you are in a hospital, or it's better to think of it like this, that you are in a setup which is capable of treating all these arrest kind of scenarios, right? So actually in PALS, we go through a very structured approach. There is an A, B, C, D, E assessment, which we call as a primary assessment. But even before that, there is something called PAT, Pediatric Assessment Triangle. I'm going to elaborate on that in the next slides. Yes. Okay. So PAT is something that is the cornerstone. Okay. This is something that is not taught to us like a structured thing, but the very first day that you step into a pediatric emergency as a resident and you are overwhelmed by all the crying babies and all the noises, this is something that is the Bible of yours. Okay. This is something you do without touching the patient. You look at the appearance, you look at the work of breathing things, and you look at the circulation. These all those things are very things that you can actually go for just by looking at the patient before really touching patients and examining them. So first thing, the appearance, whether the child is walking in or not, it's being carried on a stretcher, carried on the patient's shoulder, sorry, the parent's shoulder, or the child is walking in. So that can show you the alertness. If the child speaks to you nicely and all interacts with you, that's okay. Now, consolability, since we are dealing with children, if the child is crying so much, and whether the parents are able to console or not. See, you are a doctor, you might not able to console a child. I am usually able, but not most of us are not, because children are very, very dicey sometimes. Because and very much sick children are very dicey. They will never be consolable. And the look, there is something that our like my very, very, very favorite senior taught me, that in those 3 years you really really have to develop a eye, that whether a child is looking sick or not, whether the gaze is hazy or the gaze is like alert and pointed or not. You have to really see that. And speech or crying, whether the child is doing some confabulated speech or just like inconsolably crying. These things like crying inconsolably, vacant look, okay, or unconscious, those things ring some alarm bells in your mind. Second is work of breathing. Work of breathing, just by looking, you can just raise the child's shirt over the chest and you just look for those things that I think I have taught all my juniors and I'm going to tell you all. Never, never, never neglect the intercostal retraction in a child. That is a omnia sign. Intercostal retractions in a child is a very bad thing. If you see it at any time, don't just administer oxygen or give nebulization. Please, please, please shout and ask for help or go for a pediatrician. And if in our hospital, if we see any retraction, we immediately alert the PICU for ventilatory support because retractions don't just appear like this. So then you can see the nasal flaring. Nasal flaring is something that is also a very ominous sign. One more thing we were taught, like head nodding, like this. If the sternocleidomastoid, the accessory muscle of respiration, is used by the child just to support the child's tidal volume exchange capacity or minute ventilation capacity, that is also a bad sign. So all these signs of increased work of breathing are going to ring some alarm bells in front of you that this is a sick child. And in case of circulation, you are not going to see the heart rates. Heart rate you are going to connect to a ventilator, but you're going to see whether the child is pale or not, whether it's mottling or not. Okay. So from this PAT, what we are going to infer? We are going to infer whether the child is having any sort of life-threatening scenario or not. Okay. That is the cornerstone of the first stage of the ALS. That whether this is a sick child or it's a life-threatening scenario. If any of this, like the child is completely unconscious, the child is not breathing, you check for the pulse, there is no heart rate, you know what to do, you immediately start CPR, right? If the child is conscious, but the breath is like you are listening to this kind of strider sort of thing, you can suspect some sort of upper airway obstruction. You can ask for things. And if you see some kind of foreign body is there, you are going to give those back slaps and Heimlich if it's a bigger and older child. So you do that. So whatever you do or intervene, it's the cornerstone is the pediatric assessment triangle. So next we go for primary assessment. Okay, so if it's a sick child, it's a sick child and the child is still not in arrest scenario. Okay, the child has not arrested, but it's a sick child, you know. So you are going to go for a team approach. These things you are taught beautifully in ALS, I must say. But if you see it's a sick child in sort of a emergency intervention, then you are going to assemble a team and you are going to give some certain duties to each member of your team. Like suppose I say, Dr. Navunil, please take care of the breathing of the child. Dr. Rimjim, please go for history from the patients and take counsel them also. Dr. X and Y, please kindly look for the airway and establish airway and take care of the ventilation. Dr. Navunil, if you are free, then please go for the IV cannulation and charge the defibrillator. These things are taught very beautifully in the ALS things. So after this, after you assemble a team, and if it's a very sick child, you are going to go for a structured primary assessment, the very familiar ABCDE. What is that? First, look for the airway, whether the airway is patent or not, whether there is an obstruction or not, and one more thing, secretions are not. Secretions are there or not. So if there is obstruction in the airway, you can go for those airway opening maneuvers. You can establish a airway. So from the airway assessment, you are going to infer whether the patient has a airway which is open, which is maintainable or not maintainable. If it's open, then fine, proceed for the next. If it's maintainable, you can err on the side of caution and then go for the next. And if it's not maintainable, immediately the person who is charged of the airway is going to put in a LMA or intubate the child. It's better also that okay, in terms of intubation, it's we have like some research is there which has shown that if you are not able to intubate, because that is also a process which is requiring of skill, right? Not every one of us is going to be capable enough or comfortable enough intubating a child. you can go for a proper bag and mask ventilation. That can also give you proper airway uh, airway intervention. That can also be done in place of intubation. If you are able to intubate within 30 seconds, rapid sequence in a collapsed child, you don't give any medication, nothing, no pre-medication, whatever, you just go and intubate. If you are able to do it within 30 seconds, very well done. Then go for breathing. If the airway is patent, what is breathing? Respiratory rate, something us pediatricians are very, very fond of. And we look for 1 minute. We never multiply by 6 or by 10, like in pulse. Rate, respiratory rate, we always look for a whole minute. Okay. And some other fine points are there. And again, effort. As I told you, now work of breathing, whether the accessory muscles of respirations are needed or not. Accessory muscles of respiration, if there is needed, that implies that the child is not being able to maintain the respiration by himself. He needs his own extra help. So you are going to provide some help, like you are going to give some ventilation assessment, assistance, not assessment. Like you are, if you have a CPAP machine handy in your ER, you go for CPAP. If you have a NIV in your PICU, go for an NIV, non-invasive ventilation. Okay, next, circulation. Very, very, very important. Capillary refill. Skin signs means whether there's mottling or flushing, and heart rate. So here comes the importance of shock. Circulation is done to assess the shock. Okay, whether the child is needing any sort of bolus. If there is a hypotension that, suppose very commonly we have encountered a child has like diarrhea for 5 days. It comes to us in an almost obtunded state and the tongue is entirely dry. The skin pinch, just as written in the books, goes back about 5 seconds. So all of this gives you some alarm bells. So this is a life-threatening scenario, obtunded child. Breathing is okay, airway is patent, but in circulation we find the pulse volume is bad, it's very low, or thready pulse is there. The extremities might be cold, so that also is some kind of a difficult thing for us, because in any case extremities cold means the veins are collapsed. You are not going to be able to establish an IV cannula. So in terms of circulation, whether you find anything to intervene, if you find a low pulse or if you find it's a trauma patient, there are signs of blood loss, you immediately intervene by putting in an IV or intraosseous cannula. Even though I don't know any of us has done it, I have not done it. I would like to do. But were taught in ALS that intraosseous can actually save lives. Just the BT needle that you have in case of children, it's very easy. Just to look at the tibial tuberosity, just below and medial to that, you find the shin bone, which is the subcut bone of the body in any person. In a very fat person like me also, I can still feel my tibia and though that extra exact point. So you can just enter the BT needle exactly like you do an LP. You insert it, you feel a loss of resistance, then you can find the marrow. Just if you aspirate it via needle, you can find some bloody things coming up. That is the marrow, and you can connect it to a catheter and just give fluids through that. It's a life-saving thing, again, intraosseous. So in case of breathing, we found circulation done. We're going to intervene by giving fluid or boluses or ionotropes. Then D for disability. Disability means all those fancy things, your Glasgow coma score. But in case of a life-threatening situation, we can go for the very easy AVPU thing. What is AVPU? It is alert. V means verbal. P means pain. U means unresponsive. Alert means the child is alert and responding. V means response to your verbal stimulus, means you are calling out the name. They are then responding. Then there is P. P means response to pain and U means unresponsive. So AVPU is something that is a very emergency bedside assessment tool for level of consciousness. But you can use the 4 scores and GCS and everything after the child is PICU. Then pupils, very, very important. You are supposed giving your CPR in a case of a polytrauma patients. We have seen this actually. We had an unresponsive child who had actually had a seizure and then come to our emergency. Then we found the child in state of collapse. So immediately our juniors started all this. By the time we were called, the seniors were called from PICU. We came and we checked the pupils. One pupil was blown. So there was already some kind of herniation that had happened. So pupils is very, very important that you check. One more thing, blood glucose. Suppose a child is comatose. and you have not checked the blood glucose. You are doing everything, ventilation, bag and mask, CPR, intubation, everything you have done, but even you have administered shocks also, okay, but the child is still not responding. So in that time, you'll check for HNTs and then find hypoglycemia. It's better that in disability only you uh, go for the blood glucose. It's very, very, very important that you check a blood glucose because, as we all know, brain's food is glucose. Okay, so hypoglycemia is a beautifully responding thing. If you just correct it, the patient like this snap and the patient is okay. Then is exposure. Exposure means I think we have all seen, right? We just turn the patient in a controlled manner. We flip the back, then again flip, and then we look for is any outside sign of bleeding, any injuries. Like suppose a patient is electrocuted. Okay, electrocuted. All things I have seen. I have once seen one person's hand was electrocuted, but the exit wound was in the leg, in the foot actually. So this exposure is important. And uh, okay, and also in this time you check the body temperature. So next is we coming to the algorithm. Okay, so Dr. Rimjim, if you can just zoom in on the algorithm part. Yeah, it's fine only. Okay, I'll explain. So this is after your pediatric PAT, pediatric assessment triangle and primary assessment. There is a in between step, as I told you, right? When in any point after looking at a sick child, if you see the child is not breathing or not having any pulse, you are going for a CPR. So this is that particular algorithm for a PALS scenario. This is an in-hospital scenario. So this is something you know very well. You go and give bag mask ventilation. Someone is in charge of airway. That person is going to open the airway and start BMV and give 100% oxygen. And someone also, as I told, it's a team game. So in my team, suppose Dr. Navonir was in charge of defibrillator. So that person is going to attach the SpO2 probe, the ECG leads, and the defibrillator machine. Okay, and switch it on. Then we are going to check for the ECG. So in this case, in this cardiac arrest scenario, as you can see, the cardiac monitoring is very important. Without the cardiac monitor assessment, we are not going to able to look at anything. So firstly, we are going to see whether the rhythm is shockable or not. So let's come to the non-shockable part first, the right side of the algorithm. So non-shockable rhythm means asystole or PEA. What is PEA? It is pulseless electrical activity. Suppose you are having an arrest, you have attached the monitor, you are seeing some kind of waves over there. It looks like something. Suppose we have, like in our ALS training, we were shown the scenario was giving us such that you have found a patient unresponsive, not breathing, no pulses there. You attach the monitors, this rhythm is shown. What to do? Many of us did a mistake of thinking it as a supraventricular cardiac supraventricular tachycardia or something like that. And we said that we're going to shock the patient. No. If you are not feeling any sort of pulse, it's never a SBT. Okay. If you're not feeling pulse, the shockable rhythm can be VF or pulseless VT, ventricular fibrillation or pulseless ventricular tachycardia. But it's never going to be a SVT. If you are seeing an SVT sort of thing and you are not finding a pulse, you are going to give epinephrine, adrenaline, the life-saving thing. Now, something is very important, the dilution of adrenaline and the dose. Okay. So, as we all know, adrenaline comes in a 1:1000 concentration. This is a standard. Every ampule of adrenaline is maintained. 1 ml contains 1:1000 dilution of adrenaline. Now we are going to give adrenaline. The dose I am going to say slowly. It is 0.1 ml per kg of the 0.1 milligram per ml concentration. So 1 mg per 1000 ml means that 0.1 mg per ml. Okay. That concentration you are going to dilute in a 10 ml. And from that, you are going to give 0.1 1 ml per kg. Repeating again, we have an ampule that contains adrenaline 1:1000. That means 1 ml of adrenaline. Sorry, 1:1000 means 1000 ml has 1 mg of adrenaline, right? 1000 ml of this solution has 1 ml of adrenaline. So that solution we are going to dilute in 10 ml. Like 1 ml we take from the ampule, we take 9 ml of normal saline, we get a 10 ml of big syringe. From that syringe, it is 0.1 ml per kg we give. So now the dilution is 0.1 ml per kg. And you are going to repeat the epinephrine every 3 to 5 minutes. And if you can if you can get a IV line, it's very nice. You can go through that. If you are not able to, in case of a shock, pure collapse, peripheries and everything, you are going to give it through IU also. Same dose you can give. And now this is a controversial thing. Why I'm saying controversial? Because these things keep on changing. Okay, this slide is from Nelson, our Bible. So Nelson textbook of pediatrics has told that we can give adrenaline through intratracheal route also. That is, the dose is 0.1 mg per kg. Now this mg and ml and all those things are a bit confusing, I know. And I'm going to again re-summarize those things. But one thing I want to reiterate again, that if you see a pulseless person showing something on the ECG leads on the monitor, don't be fooled. Give adrenaline first and immediately start CPR and go for IV or IO access. And then every 3 to 5 minutes, you are going to give epinephrine. And within that time, whenever you have the time to reassess, in every 2 minutes, usually you reassess, then you see whether the rhythm is shockable or not. Okay. So if the rhythm is shockable, you go to the shockable rhythm algorithm. I'm going to coming to that. But if it's not shockable, again, you are going to give CPR. Again, you are going to treat reversible causes. In between, you must correct all those things. Okay, you are going to establish an advanced airway. You have to intubate the patient between this time. You are going to go for capnography, or in some cases, I think capnography is not available, but you have to like check for everything. The tube should be in place and stuff. And every 2 minutes of CPR, you are going to rhythm check. And in any case, the rhythm converts into a shockable rhythm, you go for the shockable rhythm. See, algorithms are structured, but a patient is dynamic or a arrest is dynamic. So if in any point of time, a shockable rhythm can convert into an asystole, or a asystole can convert into a VF. Okay. So every 2 minutes, rechecking the rhythm is very important. So in case that we are still after 2 to 3 rounds of CPR of 2 minutes each, we are not finding a shockable rhythm. And see the point number 12. Dr. Dimjim, can you just scroll down a bit? Yeah. So there is one thing written. If there is no sign of return of spontaneous circulation, this is a standard abbreviation called ROSC. So this ROSC is obtained after some 2 to 3 rounds of circulation of CPR if you are doing it correctly. But if you are doing everything correctly and still it's not there, then we are going to some uh, reversible causes. We are going to look for them and treat them. I'm coming to them. Just let me finish the shockable rhythm part. Okay, coming to the left side of the algorithm. Okay, so VF and pulseless VT. As I told you, it can be a ventricular tachycardia, but there is no pulse. So we need to know what is a VT and what is a VF. Okay. So usually tachycardia can be wide complex or narrow complex, as we all know. If you see a wide complex tachycardia, which shows that there is some kind of wide QRS complexes that are coming, you are not seeing any P waves. Okay. And you are seeing those complexes which are like very, very, very hazy and like a very sort of a absurd, bizarre kind of complexes. So those things can be BF or pulses VT, but usually pulses VT and VF are shockable, as it is mentioned. So immediately you administer a shock, as we know, 2 joule per kg. And this shock is defibrillation. It is not cardioversion. It is not synchronized cardioversion. It is defibrillation. It is like, yes. So it is like giving a jolt to the heart. The heart was dancing on its own bizarre rhythm. You are giving a jolt and stopping the heart. That is why you immediately post giving the shock, resume the CPR. So after CPR of 2 minutes, again, you do the same thing whether rhythm is still shockable or not. If it's shockable, then you again deliver a shock. Again, 2 minutes CPR. In this case, you must know that in this case also, after administering two shocks, we are going for epinephrine. But in case of asystole, we give epinephrine first and we keep on re-administering it every 3 minutes. Okay, so these things are a bit confusing, but and I think if you come across these real life scenarios, you know, like after 2 to 3 experiences only, you are very well versed with all this. So, as I told you, any shockable rhythm can convert into a asystole at any point. If it's asystole, you immediately give epinephrine and continue CPR and again recheck. And if it's still shockable, then you are going to shock. After providing 3 shocks, now comes your time to give a proper antiarrhythmic. And the biggest, like wide coverage antiarrhythmic that we all know is amiodarone. So, and also we were treating all this as a pulse VT or VFib. So we can give amiodarone. We are going to give amiodarone. It's a 5 mg per kg bolus dose. As pediatricians, we are very fond of mg per kg things. So please don't ask me the adult dose. I have forgotten. I only know the ceiling dose. I think it's the ceiling dose for adults is 30 mg. Correct me if I'm wrong. So,
Yes, 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 absolutely.
okay,
Yes.
thanks.
In fact, I will just, I'm sorry, because since you raised this point, there are a lot of students who might be feeling what is the difference between, I think somebody is unmuted. Can you please mute yourself? Vijay sir, can we unmute? Yes. Okay. Yeah. So the point is, I think what Dr. Esha was trying to say, that there's a difference between defibrillation and cardioversion. So something that I often used to tell my juniors is, suppose a kid is very 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 naughty, and one of the parent, on seeing the naughtiness, slaps the kid at any random point of time. Any random point of time when the kid is being slapped and said, "Don't do this." This is defibrillation.
That is
Whereas
defibrillation. Yes.
when the kid is doing that naughty thing again, and then the parent is slapping, that is what is called as cardioversion. So synchronization with a naughtiness is cardioversion, unsynchronized beating is defibrillation. And what is the importance of synchronization? That you always give the shock at the peak of the R wave, because if at
Yes.
all you give it in the T wave, there is something called an R on T phenomenon that can occur, which can lead to something called ventricular fibrillation. Okay, I will
Again.
let
So
Dr.
then
Esha
then
speak now.
you need to again defibrillate. So if you
Yes,
are
absolutely. Yes,
landing a synchronized rhythm into a defibrillatory rhythm. So I
absolutely,
was going to
absolutely.
discuss it in the tachyarrhythmia thing, but thanks, Navani,
Yeah.
for elaborating this. Okay, so amiodarone is an antiarrhythmic that we give, or lidocaine we can also give. I have not used lidocaine. I have used amiodarone only. We did not need to go to lidocaine actually. So, and someone wrote 6 mg per kg. I think that you wrote that is adenosine dose. That is supraventricular tachycardia. I'm coming to that. So, after that, so see, in every step, you are going to check for responsiveness, right? So, in case of CPR, you have given shock, you have given amiodarone, still there is no response. Now we are coming to something which is called reversible causes. Okay, reversible causes are there is a very yes, that part. There is a very like catchy abbreviation, HNTs. So hypovolemia means shock, hypoxia means lack of oxygen. So hypovolemia, that therein lies your circulation. So you have to give boluses or at least attempt a circulatory function in this patient. You have to give some IV fluid. You have to establish a line or any IV or IO access. Hydrogen ion or acidosis. See, acidosis is a notorious thing. If you correct everything else and still there is acidosis, nothing will come because acidosis is a myocardial depressant. Metabolic acidosis or hydrogen ion actually depresses the myocardium. It loses its sensitivity to the catecholamines. So all these alpha beta receptors that we are so fond of, those things get sort of deactivated. So whatever you do, it's not going to come to any fruition because the acidosis is not corrected. Hypoglycemia, as I told, you should be correcting it in the disability part only. But if you have missed in by this time of doing so many things of shock and CPR and stuff, take a sample, go for an ABG, and that ABG is going to show you everything. The next thing also is hypo or hyperkalemia. Like suppose you are finding a patient with pulse and you are seeing like huge wide complex tachycardia. That is looking like a sine wave. That can be a that can be a hyperkalemia, right? After the tall T waves, it comes to a sine wave pattern. We often forget that. So reversible causes are very important. Then hypothermia. As I'm a pediatrician and very fond of neonatology, in neonate, the first thing we ensure is TABC, temperature, airway, breathing, and circulation. So hypothermia is something you must avoid at all costs. Okay. So the patient should be in a thermoneutral environment, ideally. Or suppose you are dealing with a drowning victim, the first thing you do is just get rid of the wet clothes and wrap them in a warm blanket. Then start the CPR. Then the T's. Cardiac tamponade, something that is very like ominous. You are doing everything, but there is muffled heart sound. So the heart is not able to pump out because of an obstructive shock. So nothing is going to work. Tension pneumothorax, again, obstructive shock. Toxins, like suppose someone, in case of adults, let's suppose there is someone with opioid overdose. The pupils are like of a purely addict pupil, right? Like those completely blown out pupils or pinpoint pupils you see in anticholinesterase poisoning, like pesticide poisoning. We have seen all right, the like the ekdam short, small pinpoint pupils. So toxins, if there is toxin exposure, then antitoxins can help you where all these measures can't. Then pulmonary and coronary thrombosis is something that requires a lot of expertise. That is why those things are in the later end because those are more rare. In the upper end things of the HNTs, those are things which are much more reversible. But if you have checked all these things up to toxins and then still you can't find, then you go for a CT angio and I think then you can go for a pulmonary or coronary thrombosis. But since we have an ECG monitor attached, I think the rhythm patterns can also sometimes give us some insights. Okay, so the next slide, please. Yes, so now I'm coming to my PALS secondary assessment part. Secondary assessment means this patient was not in arrest. The patient was in a primary life-threatening situation for which you have assessed A, B, C, D, E, and now the patient is a bit stabilized. Now we are going to go for sample history. I think this is very familiar, so I'm just going to go through very fast. First, the sample is a algorithm, is a abbreviation. S means sign and symptoms. Why the patient came here? What is the chief complaint? If there was an existing situation, any change in the condition. A means allergies to any medications or foods. A means any regular medication that was going on. P means past medical history, whether there was an hospitalization. Suppose an anaphylaxis patient has come. The patient is allergic to prawn or seafood. So you are going to ask whether this has happened before or not. L is last oral intake because you might need to establish an airway. So there is a risk of aspiration. So you are going to ask for that. And E is events leading up to the illness. So this is a sample history that is done in secondary survey. Now there is secondary assessment, and if you can see, it's fairly simple. Full physical examination means actually we have checked the ABC, right? Airway, breathing, and circulation, but we have not seen the suppose heart murmur. We have not seen the liver. We have not seen the spleen. We have not assessed, suppose, for any edema or something like that. So we are going to do all those things. We are again recheck the vitals. Supposing airway and breathing, we have done some interventions. We are going to recheck whether the vitals have improved or not. Then focused evaluation, as I elaborated. You know this is a poisoning. You know this is a seizure. You know this is a post-icteral state the patient has come in. Someone I think has wrote about febrile seizures. Febrile seizures, just after one seizure, the child comes, the child is sleepy, the parents are very anxious, but we admit the patient and monitor for next 24 hours if it's the first episode. That the only thing we look for is whether it's recurring or not. Otherwise, we give nothing to the patient. And if that seizure has occurred very recently, we just attach an IV cannula, put the child on fluids. After 6 hours or so, if the child is awake and there is no seizure, we also start feeding the child. So febrile seizure, it's a very normal thing for us. We have managed, I think, many of them. And the thing that is important is whether the seizure is recurring or not. So if it is recurring, then we are not going to go for such a casual approach. If it's recurring, then we are going to do the um, LP and EEG and all those things again beyond the scope of this. So focused evaluation is important in this manner. Glasgow Coma Scale. So earlier in disability, you have used AVPU. Now you are going to present in front of your consultant. That person, when listens to AVPU, gets very angry. He starts giving you gali. So you go for the GCS. And you, or if you are very fond of extra brownie points, you go for a 4 score if the patient is intubated. Again, recheck the glucose level and for pain level, assess the pain scale. Okay, so there are some pain scales in pediatrics. There are some specific pain scales, like in neonate, there is CRI score and all those things. Again, very subject specific and beyond this. So I think I am able to summarize the secondary assessment. So in every step of PALS, we go for a focused assessment, a systematic assessment. You go for ABCDE. If in any point there is no pulse, nothing, you go for a collapse algorithm and you go for the CPR and things. In CPR, you recheck the pulse, you recheck the rhythm, you deliver shock. If it's not shockable, you give adrenaline. So all those things. And now on the next slide, we're going to deal with some specific scenarios like bradycardia. Okay, so as we all know, it's often due to hypoxia. We are going to maintain the airway first. And if it is a less than 60 heart rate and there is no signs of good perfusion, we are immediately very, very anxious and we are going to go for the approach. So next slide, please. Okay, so bradycardia with less than 60 with poor visible signs of perfusion. That means the patient is pale. There is CRT is prolonged, capillary refill is prolonged. That means we are going to go for CPR algorithm. Okay. Immediately we go for CPR algorithm, but it's a bradycardia with a pulse. So less than 60 heart rate, but pulse is there. Now we are going to check whether the child is entirely comatose or not. Is there any sign of shock or hypotension? See, shock and hypotension is mentioned separately. I think I am clear because hypotension is the last thing that alarms us because it's the last thing that goes wrong. Before a child comes to hypotension, there is many phases the shock goes through. So hypotension means an uncompensated shock, and that is a very, very, very bad thing. You should be very scared of an hypotensive shock. So if the mental status is not altered, all those alarming signs are not there, you go for the very basic things. You maintain the ABC. I think Dr. Rimjim, if you can just zoom in the right part of the algorithm, upper part, please. A bit upper. Yes, thank you so much. Yes. So you support ABC, very basic things. Just get the patient to an ICU, put the cardiac monitors, give oxygen, and you just look for the cause. You become the Dr. House and search for them. But if it is a grave thing, there is a problem of shock, there is a hypotension, there is altered mental status. Again, you go for ABC. Now you are very, very, very much interested in aiding the breathing with PPV, positive pressure. And you're going to give cardiac monitor. Now, just below that, see what is written. As I said time and time again, less than 60 means immediately, instantly you start CPR and you see after 2 minutes whether the bradycardia is persisting or not. If it's not persisting, then you again go back to the normal thing, support the ABC, basic things you do, keep the patient in PICU. And if it is still persisting, then you are going to get to those epinephrine. Now, there is something written below epinephrine, I think. It's atropine, right? Okay, so if you are very sure it is a AV block, then only you give atropine. Otherwise, it's always safer in a pediatric patient to just use adrenaline. Much safer. If you are not sure the bradycardia is due to increased vagal tone or not, don't use atropine. You are not going to do any benefit to the patient. And again, below that, after doing all those things, if there is still some kind of no response, then we do that, right? I think we have all seen like transcutaneous pacing or like temporary pacemaker placement. You can do that. So through a central access, you take the child to PICU and you can do that. But in between, you can always, you can no, not you can, you should always recheck pulse, and pulse is present or not is something you are very, very, very particular about. If any point you lose the pulse, if any point the CPR is not adequate, or if any point the heart rate goes less than 60, you go for the arrest algorithm and you proceed in that manner. In the small box, the doses of epinephrine is given. Epinephrine dose is same as arrest dose. Atropine is 0.02 mg per kg. And you just repeat once. That's what I told, because epinephrine is something we are comfortable giving in, and atropine we don't really use much. And now, as it's written in the small box, hypothermia and hypoxia is something you must correct. Often bradycardia is due to hypothermia, very common in neonates. Often a neonate goes to a 70 or 80 heart rate, brady for them. So then we just switch on the warmer and everything is okay. And medications, like suppose the patient is already on some kind of antiarrhythmic, so that can also actually, I'm sorry, that can also just deter things. Okay, so next slide, please. Okay, I think we have covered this. Yes, now my favorite thing. I'm very partial to tachycardia with a pulse. Why? Because it's very interesting, and as you can see, it's a bit daunting also. Okay, but we are going to go stepwise. So first, the green big square or rectangle, if you please. Yes. So it's a tachycardia. Now, in pediatrics, what is a tachycardia? It is something that is very, very, very bizarre, but for us, for adults, it's over 120 or over 100. So in pediatrics, the normal heart rate can go in the range of 120 to 140. So some alarming figures are there. Any point, if you come across in a child or a neonate, a heart rate over 220, that is a definite tachycardia. Or in an older child over 180, that is a definite tachycardia. Okay. So in case of a tachycardia with a pulse, we are going to do the very bare minimum basics first. We are going to establish an airway if there is needed. We are going to assist the breathing. We are going to give oxygen, and we are going to attach the cardiac monitor, because we need to know where this is a sinus tachycardia or this is any other kind of tachycardia. And as we all know, IVIO axis and ECG. See, the initial assessment and support, if you look at it carefully, it's A, B, C, D, E. Some parts of it, right? I think you can appreciate. Okay, so after evaluating the ECG, we are going to see whether it is a sinus tachycardia or not. So sinus tachycardia means certain things. It's very easy. PQRST. If the P waves are present, it's sinus. If there is any variable RR interval, it is normal. In infant, it is less than 220. In child, it is less than 180, as I told you. So in these cases, the sinus tachycardia might be because the child is having a fever, or this child has, very common in our scenario, child has just nebulized. with levosalbutamol. Okay. After that, we often see like 170, 160, these kind of heart rates. So just take some time and treat those things. Now, if it's not sinus tachycardia, then we look for altered mental status, shock, and hypotension. If any of it is present, then it's an alarming thing. Then we are going to go for evaluation of QRS duration. So it's a altered mental status of patient. There is QRS duration evaluation done by us. Okay, so I think these time mentioned, like the duration mentioned for QRS, is specific for pediatrics. So I'm not really very sure about whether this extrapolates to adults. If there is any difference, I think someone else can just correct it. But if you look at
Yeah,
the QRS duration,
we'll be dealing with the adult things on 27th when I'll be taking the webinar. Yeah.
okay,
So
okay,
yeah.
no problem. So the narrow QRS tachycardia is less than 0.09 seconds. That is approx like very two small boxes, less than two small boxes. That means it's a narrow, and it's wide means it's more than two small boxes. So if it's narrow, then we are going to think it might be a supraventricular tachycardia. And there are certain pointers. The algorithm might look daunting, but it's actually very informative. So if it's supraventricular, then a very, very, very characteristic thing is there that P waves will not be there. The RR intervals will be regular. See, this is a very, very key point. In sinus tachy, the RRs will be varying, but in SVT, the RRs will not vary. And as I told, since this is a supraventricular tachycardia in infants, we are going to have a 220 or above heart rate. In child, it will be more than 180. And there will be an antecedent history of abrupt increase in the heart rate. Okay. So now we are going to see if the child has a cannula. Very well done. But even if the child does not have or has a cannula, which is suppose in the dorsum of the hand, we are going to do a cannula which is closest to the heart. And I think um, as someone who has seen remarkable benefits after adenosine, it's very important that you administer it correctly. So just give me 2 minutes to elaborate how to give it. So adenosine, as we all know, is a very short acting thing, right? It's just 10 seconds it takes to exert its action. So you have to give it in a vein that is very close to the heart. So what we prefer is a brachial vein. We use the cubital vein for cannulation and we give it. So after you have cannulated the cubital fossa or you have a cubital access, you just apply a two syringe and a three-way cannula. So you um, attach the three-way cannula to the IV cannula. Okay, and then direct in line with the like in the straight line with the IV cannula, you keep the adenosine and just right angle to that, as there is usually in a three-way, you give the flush. So just you use your two hands to give the uh, flush. Like you have to simultaneously give the adrenaline and sorry, the adenosine and then the flush. But two people can't give. Okay, you only have to give it by yourself. Just you have to synchronize it. So just we give the 6 mg per kg adenosine. Then we just give the flush, and it's given here. If it's not available, then we are going to go for the synchronized cardioversion. Wonderfully explained. We go for the defibrillator. We attach the defibrillator monitor. There is a sync button. We press it. Then you will see in the ECG there will be a dot or something or a prompt coming with every R wave. So that will show you that it has synced. Now you are going to administer the shock. So that's how you provide the synchronized cardioversion. Okay. So this is one part. Now, if it's a wide QRS tachycardia, so this can be a ventricular tachycardia. And as you all know, so this is a need for synchronized cardioversion. It's not a pulseless VT. Okay, something is important. If it's a pulseless VT, we are going to defibrillate. But this is the VT. So we are going to go for a synchronized cardioversion. I think there should not be any more doubts regarding this because I am someone who has doubts regarding this. This is why I am just elaborating it time and time again. So after this synchronized cardioversion, something is written here. You see, expert consultation is advised before additional drug therapies. So if it is a VT, then you go for cardioversion, and then by that time you are going to give a refer to a cardiologist or paid cardio person, and that person will come and take care of things for you. So now we dealt with an unstable patient. The child was with a tachycardia, there was a pulse present, but there was some shock and hypotension and altered mental status. So we assessed whether it was SVT or VT, like narrow or wide complex. If it's SVT, give adenosine first, then synchronize cardioversion. And if it's VT, just give cardioversion. But if adenosine is not present, in case of SVT, you can just go for cardioversion directly and give adenosine later on. Okay. Adenosine, I think, can be given up till 6 into 6, 12. 12 mg per kg total can be given in a child. And one ampule, I think, contains 6 mg only in adenosine. And now QRS, okay, now coming back to the algorithm again. So now we are going to deal with a bit stable child. The child was having a narrow complex the child was having a pediatric tachycardia, but there was no cardiovascular compromise. So again, whether it's a SVT or VT, if it's SVT, now we are going to be a bit conservative and go for vagal maneuvers. What are vagal maneuvers? The very, very favorite of old people, Valsalva. But we don't do that because children are not going to listen to you at that point of time. What we can give is you can just put some ice cubes or ice pack over the eyes of the patient. All those ocular massages and carotid massages, something is that is not recommended right now. You can give. I have given carotid massages in a SVT that actually responded beautifully, but you are not supposed to do. So, and if after vagal maneuvers the SVT is persisting, then you are going to give adenosine. Okay, and if adenosine does not work, you are going to go for synchronized cardioversion again. It's fairly simple. And after suppose adenosine and synchronized cardioversion, still there is no improvement. In those cases, we can go for actually we can go for flecainide and all those things. Sometimes we can go for diltiazem and all those things, but it's a bit a detailed thing and again beyond the scope of this. And I think both of the sides of the things are pretty similar. And if it's a wide QRS, it's VT. If it is regular and monomorphic, you give adenosine. If it is not monomorphic, polymorphic VT is something that we are all very fond of saying, something called torsades pointi. So we are going to give magnesium. It's not going to respond to adenosine. In monomorphic VT, you can go for adenosine only. Okay. But it's always written that you just go for a pediatric cardiologist. Okay. So the next slide, please. Yeah, see, now I have told a lot of things, but it's not possible for me to teach all the arrhythmias in the PALS thing because arrhythmias are a huge, 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 vast thing. So these slides are meant to reiterate what I have told in the algorithm things. So in tachycardia, what things you keep in mind, whether it is narrow or wide, whether the patient is stable or not, if it is SVT or not, and we identify the shockable rhythms. So say this inside your head. Shockable rhythms are SVT, VT, VF, and pulseless VT. Four things are shockable. But the shocks differ. SVT and VT, like monomorphic VT, those things require a synchronized cardioversion. But the pulseless VT and VFib, they require defibrillation. Okay. I think there should not be any discrepancies regarding this. So those two ECGs, I think every one of us knows. This one, the green one, very classic for a PSVT. As you can appreciate, the RR intervals are regular. The heart rate is about more than, this is an adult ECG actually. So it's actually more than 150 approx in this thing, I think. I'm not able to see, it's very small in my screen. But you can very well appreciate the lack of P waves, I think, in the green ECG. There is no P waves, right? So no P waves, this kind of a thing. There is a pulse present. What you're going to go for? Give adenosine if you have IV access. Otherwise, go for synchronized cardioversion. Okay. The red one, that is a classic ventricular fibrillation. You can see, right? It's a like sine wave kind of a thing. The red ECG. So I think wide and narrow QRS tachycardias are appreciable. So the next slide, please. Okay, just to put into our minds again, SVT management in case of a stable patient without signs of hemodynamic compromise, first go for vagal maneuvers. What you are going to do, just keep some ice cubes or ice packs over the child's eyes. Okay, if it's an older child, you can do one thing, ask them to blow through a straw. That is simulating Valsalva, that you can ask them to do if they are cooperative. And if it's an adult, you can ask them for Valsalva. Don't do carotid massages and all those things. And adenosine doses, I mentioned 0.1 mg per kg. You can repeat 0.2 mg per kg. And the maximum dose is 6 mg per kg. Up to 12 dose. Like maximum doses for a single dose, max is 6 mg per kg, I think, which is the adult dose. And max you can go for 12. Then synchronized cardioversion, as Navneet beautifully told us, sync to R waves and then deliver the shock. So next slide. Yes, as I mentioned earlier only, the graphic beautifully consolidates what we have told, but I'm not going to say the same things again and again. Just putting into your mind what is a shockable rhythm, that is VF and pulses VT, and also our SVTs, right? But this is the cardiac arrest rhythm, so SVT does not come into an arrest scenario. But VF and pulses VT are shockable rhythms. But if you are not finding a pulse and you are seeing something on the ECG monitor, don't be fooled into thinking it's an SVT, it's a PEA, pulseless electrical activity. And if you're not seeing anything on the monitor, jump into CPR and save the patient. Okay, next. Okay, say more of the same. More of the same is there. Now H and T's. Okay. Now next one, please, Dr. Rimjin. Yes. So H and T's is something we come across which are very, very important. Why they are important? Because they are reversible and they treat the underlying pathology. Okay. So next, hypoxia. Suppose you have gotten a child who is unresponsive, but you don't know the child has a foreign body. Inhalation happened. Okay. So that is an upper airway obstruction, and the unconsciousness is due to that, but you don't know. And you have not corrected the hypoxia. You have done CPR, but you are not able to effectively correct the hypoxia. In that scenario, nothing will work. So airway obstruction, that is why is very important. Actually, in BLS, one thing you can also do. It's actually said that if you see a choking happening or a foreign body is something suspected, in between the rescue breaths, okay, before giving the rescue breaths, you actually should check into the mouth of the child or the patient. If you can see any foreign body, you can do a 2-finger scoop and put it out. And if it's a child, you have seen a choking happen, then you just put the child over your forearm and in a prone position and give a back slap like this, in this kind of a manner, until the foreign body comes out or the child loses consciousness. If the child loses consciousness, then again you start the BLS CPR algorithm in case of airway obstruction, foreign body things. And if it's a bigger person or a child that you can do a Heimlich for, you jolly well go and give a Heimlich to expel out the foreign body. Again, same thing. You give these things to dislocate the foreign body until it comes out, or you go for an unconscious patient. Then, in between the CPR cycles, while giving the rescue breaths, you look for the mouth of the patient and check whether the foreign body is present or not. If it's visible by your eyes, then you just uh, discreetly scoop it out. Okay. Now, next, please. Yes, hypovolemia is something that we suspect when there is clear hemorrhage, clear dehydration. It's written treat with fluids, but there is something of a nuance here. Okay. So if it is a hemorrhagic thing, then fluids alone is not going to help. You are going to have to give blood or blood products. Hemorrhage often leads to something that is called a triangle of doom or death, because if you just keep on pumping the child with NS, that is going to create a hypochloremic metabolic acidosis. So that is further going to actually derange the coagulation cascade, and the patient will start landing up into a DIC-like situation. Okay. So in case of a hemorrhage, obviously you start with IV fluids. You give, in case of a child, we start with a 30 ml per kg bolus. We give it over 20 minutes. We can give it in a flash push pull method also. But we must also arrange for blood grouping and cross typing, and if not available, then ONEG and FFP and platelets 1:1:1, like PRBC FFP platelets 1:1:1. We administer, we initiate massive transfusion protocol, and even after this 1:1:1, if this not corrected, there is some derangement, we can give cryo, we can give factor precipitors, everything. So hemorrhage is something that should be treated with blood products in adjunct to fluid. Fluid alone cannot manage your hemorrhage. And also something is very important, that don't miss the source of the hemorrhage. You are keeping on giving blood and fluid and everything, the patient is bleeding internally. Nothing is going to happen, right? So keep those eyes open for that. Dehydration, something I can't tell in very detail, but I think all of us know now in like this IMNCI protocols, plan A, plan B, plan C. So what is very important in dehydration is, in pediatrics, the nuance is there that we don't overcorrect or overpump children with fluids. We are very generous with other things. We're very generous with nutrition. But yeah, I'm coming to that only, Twinkle. So we are very generous with nutrition in the patient, but we are not generous in pumping the patient with too much fluids. But in case of a dehydration patient, the first thing you do is to assess whether the patient is in shock or not. A dehydration patient can be in shock or cannot be in shock. Okay. I'm just telling about a normal child. I'm not telling about a malnourished child. The child is malnourished, that further complicates things. But if the child is a normal nutrition child, suppose just having a food poisoning and after some 5 days of diarrhea, the last day, the day before coming to you, the child is having 10 to 12 episodes of stools per day, has no urine output for last 6 hours. Very common scenario that we have in our ERs, and has completely collapsed veins. Okay. The child is exactly obtunded and stuff, but still breathing. Heart rate is just tachycardic. So the child is still in compensated shock. Okay, the peripheries are warm, it's flushed, there is a capillary refill that is less than 2 seconds. So it's a warm kind of shock. Warm shock, that is compensated shock, is there. So first thing we do is we correct the shock in this child. That is, the bolus is given. Bolus is something we give to correct the shock. And then the plan B, plan C things come, all those 30, 70 corrections that we have learned. I think all of us know. Those things come, they are actually deficit correction. And then something that is pediatricians are famous for, the holiday Sager, 100 ml per kg, then 50 ml per kg for body fluids and 24-hour maintenance. That is the maintenance fluid. So in case of a child with dehydration and hypotension, first thing you do, not hypotension, dehydration and shock, the first thing you do is correct the shock with a bolus. After bolus, you reassess whether the child has a increased liver or not, whether there are basal crepes or not, like liver span is increased or not. Right? Because if after giving a 30 ml per kg bolus, you listen to the heart and you find a huge VSD murmur, then you can't give further boluses. Actually, the 30 ml per kg bolus itself was further not indicated in that child. But things happen, we have seen it happen. So that is why before giving each bolus, we have to reassess the patients. So what do we reassess for? The basal Krebs and the liver span, and we just palpate the liver. And that is why you see the secondary survey comes in handy this time, right? You go for ABCDE, you are correcting C. You have given the bolus intervention as a C correction, circulation correction, right? But in the secondary survey, if you don't go for vitals or if you don't go for a focus examination, you are not going to find the VSD murmur. You are not going to find the basal Krebs. You are not going to find the liver span. Okay, so those things are very important. This is why. So after that, you go for, if the liver span has not increases or there is indication that you can still give fluids, or now we have focus, point of care ultrasound, we just go for the IVC collapsibility. We look at that, we look at the cardiac contractility, and then we give further fluids. After two boluses of maximum 60 ml per kg fluid, if there is still signs of shock, that is still tachycardia is there, still perfusion is not improved, then we go for inotropes. If it's a warm shock, the first line usually is not adrenaline. If it is a cold type of shock, peripheries are cold, mottled, we go for adrenaline. And other things are there, like if you know that this is a cardiac patient, it's a VSD patient, the patient is already in shock, the peripheries are cold, you can give just 110 ml per kg slow bolus over 1 hour. Don't overwhelm the patient with fluids. And next, you go for dobutamine. That is our approach. So I think the shock treatment is clear. And dehydration, I think, is also clear. In dehydration, you actually treat three things. Okay, thank you, Twinkle. With dehydration, you treat three things. You correct the shock or um, the shock first if it's there. You correct the deficit after correcting the shock in 30-70 over some hours, approx 6 hours you correct the deficit, and third you correct the maintenance fluid. Okay, so coming to hydrogen ion, as I told, myocardial depressant, so it decreases contractility. So if you are not going to give uh, correction for acidosis, it's going to create problems for you. Next one. Yes, hypo or hyperkalemias, actually both of them are very dangerous. Neither of them is any less. But hypokalemia is usually the flattening of the T waves, right? And hyperkalemia is the famous things like tall tented T waves. There is actually a sequence. For the first it gets tall, then it gets tented, and then there is sine waves, and then after that there is completely like disarray of rhythms, and it goes into a very bad thing. So that actually corresponds with potassium levels, again beyond scope of this. But after looking at something of an ECG pattern in a background of hyperkalemia, you can say what was the potassium level. And what is the treatment of hyperkalemia? I think all of us know. First thing we give is calcium gluconate. We first give calcium gluconate to stabilize the heart. In children, we give it at 1 ml per kg. In neonates, we give it at 2 ml per kg calcium gluconate solution. We dilute it with the same volume amount of 10D, and we charge it in a syringe pump over 30 minutes. And it is necessary in your instructions, you must write under strict cardiac monitoring. Okay. And also before administering calcium gluconate, you must ensure that the IV line is patent and it's not leaking in any way, because calcium can cause necrosis in the vessels. I've seen it happen many times. Okay. Especially in neonates. So you give calcium gluconate. After that, you give insulin and dextrose solution. In case of hyperkalemia, you give insulin dextrose. You first, let me just elaborate because I have given all those things. So you just charge a syringe pump, and actually what we do is, I think those who have seen syringe pumps can relate that we just use a tubing with the syringe pump, right? In case of insulin, it's very important to flush the tubing first with the insulin solution. So you just make your desired insulin dextrose solution. I think 0.01 unit per kg is usually given. And no, actually, in pediatrics, actually, unless it's DKA, we always, in hyperkalemia, we give insulin with glucose only. Only in case of DKA, first, after ensuring potassium is right or not, then we give for insulin, okay? Insulin, just plain insulin. Okay, so hyperkalemia, insulin, the tubing is to be flushed. I think in adults also, you should ensure that these things are done by the nursing staff or not. If you're just writing your orders and something else is going to happen, okay? I've seen it happen many times. So you have to ensure that your instructions are followed. So those insulin, because insulin is a particulate thing, regular insulin, that gets stuck in the tubing. So we have to just flush the tubings with insulin first, so the proper amount reaches to the patient. After that, then 0.1 international unit per kg you charge and you administer insulin. So that is a definitive treatment. And some adjuncts are there like potassium binding resins, not much used in pediatrics. And sometimes we give, that is your salbutamol nebulization. That works, doesn't work, but usually what is important is you go for a insulin dextrose, that is definitive, and first and foremost give the calglu. What is important about hypokalemia is an adjunct electrolyte abnormality often coexists with hypokalemia, that is metabolic alkalosis. If the patient has a metabolic alkalosis, whatever you do, whatever hypokalemia you try to correct, is not going to get corrected. First, treat the metabolic alkalosis, okay? And how to treat hypokalemia, you give potassium. How to give potassium? That is, you just create a stock solution, and actually the dose is 0.2 mg, not mg, 0.2. Just give me a minute. I'll come back with the dose of hypokalemia correction. Right now, my memory is not serving me. But what we used to do is we used to make a stock solution from which we used to take, I think the normality of the potassium solution was taken into account and we used to correct. So it was, or something very easy thing you can do. Usually we give a fluid 100:1, like 100 ml fluid has 1 ml of KCl solution. Okay. Okay, I remember. It's 0.2 milliequivalent per kg.
Yeah,
The
0.2
dose.
milliequivalent per kg. Yes, I was just about to say this. Yeah.
Yeah, Amar, the process I remember, then the memory comes back.
No, no, it happens.
So
Thought block is very normal in us. We are all growing old.
no, it's just because I'm a bit, my practice was much more regular before, na? Right now it's a bit delayed. So that's why the time is like this. Okay, so continuing on, 0.02 milliequivalent per kg is the dose. You create a stock solution and you calculate what is the 0.2 milliequivalent per kg dose. And creating a stock solution and those things are better left to the pediatricians, I would say, because so much of innovation will overwhelm you. So I'm not going into that, but I can still tell you it's fairly easy only. But you just make that, you then give 0.2 milliequivalent per kg, and then over 1 hour or 30 minutes, if you are very much in a hurry, you first give the bolus of KCl. Then what you do is you increase the maintenance KCl. You add extra potassium, like 100:1 you normally give, 100:2 you give. Like in 100 ml of fluid, for each 100 ml of fluid, you give 2 ml of KCl, okay? Like that. So actually 1 ml of KCl has 2 milliequivalent of KCl. So if you give 100:1, that means you're giving 2 milliequivalents per kg of KCl. If you give 100:1.5, you are giving 3 milliequivalent per kg of KCl. Like that, you can increase the maintenance dose. But very important is you correct the metabolic alkalosis. Okay, next slide, please. Yes, hypothermia, as I told, during exposure, you must take the temperature, and if it's a drowning victim, just get rid of the wet clothes. And hypothermia is actually very, very, very important in case of sepsis control. Hypothermia will actually further propagate the sepsis. And also rewarming required. Rewarming, I think, rewarming required. This thing is not really actively done. What we do is we try to maintain a thermoneutral environment, and we usually give a warm blankets or warm saline to the patients. Okay. But what is very important, what hypothermia actually does, something you must remember why I am stressing this. Hypothermia has a very bad effect on the coagulation cascade of the body. Okay. Hypothermia actually deactivates many enzymes. As you all know, in enzymes, there were those temperature things. Some correct temperature is required for the enzyme's activity. Hypothermia actually creates problems in that. And the enzyme cascade of coagulation is very much affected, which is why in case of a child, in case of, sorry, not a child, in case of a neonate, if I find a hypothermia, the first thing we give is vitamin K, just to ensure that the coagulation thing is okay. So you can also consider vitamin K in this regard also. There is no harm in that. You can give that. Okay, so next slide, please. Okay, so this is very, very, I think, appreciable, right? The left side of the lung is collapsed and into a like wedge-like structure. Outside that, you can see a entire black thing. How can you know this is not a lung? Because there is no bronchovascular margin in that blackness. And if you see the right side and compare it with that, you will see right side is a lung because there is bronchovascular margins present. And in the left side, surrounding the collapsed lung, is the huge pneumothorax. So this needs a emergency management. Okay. So there is one thing called DOPE. Okay. Yes, the previous slide. Thank you. There is a thing called DOPE. DOPE. What is DOPE? DOPE is something while during all those resuscitations, in each step of like the pulse check and all those things, you have to look out for these things also. Because in DOPE, the first thing is D, dislodgement. Dislodgement of what? Endotracheal tube. Very common. You have intubated the patient in the emergency and taken to the PICU. In the transit, the tube gets dislodged. Have seen it happen many times. Okay. Okay. O is obstruction. Obstruction is your junior has slept all night, has not checked for the patients, and in morning you come, you see the tube is obstructed, the secretion has blocked the tube. P is pneumothorax, what you are seeing here. So P is pneumothorax means you have very enthusiastically suppose given a bag mask or you have not given an adequate pressure. Too much pressure has perhaps given, or this is the right side lung, right? The tube was in the right bronchus. And then you have not properly positioned the tube. One side lung has got into a pneumothorax. Happens more often than not. Not desirable, but happens. So P is pneumothorax and E is, I am again not finding what is E. Someone please answer. I'm not going to say everything. Very easy, extubation. We were talking about a tube, right? The tube can get dislodged, the tube can get obstructed, the tube can result into a pneumothorax, or there can be an extubation. So we are going to look for dope things because in resuscitation, to ensure the airway is okay and all the steps are necessary, you have to look for basic things. So the P is tension pneumothorax here. So pneumothorax needs emergency needle decompression. So what we do is in the second intercostal space, be very clear about this. In the second intercostal space, just into the mid axillary line, into the lower border of the upper rib, in that space, you just give a needle. How do you give a needle? You just take a, like our normal cannula only, you take that, you just put into the space, you take out the stylet and immediately connect the end of the cannula with a seal. How do you make the seal? You just connect a IV fluid drip set into a water seal sort of thing. You can take a normal saline, right? Just connect the drip set to the saline. Immediately you will see bubbles coming out. Very, very, very comforting to watch. And you will see some improvements very immediately. So before you can get ready to give a chest drain, which is also very necessary in this scenario, ICD. So you must do a needle that can save lives. And how to give an ACD? Not ACD, sorry, ICD. Pardon me. ICD is given in the fourth or fifth intercostal spaces in the triangle of safety. That is the landmark there is the mid-axillary line. Okay. So, why the pneumothorax correction is important is if you don't correct it, it will end up in an obstructive shock. So, how much ever CPR you do, the blood cannot be pumped out by the heart. Okay. So, next. Yes, coming to another very important thing, another cause of obstructive shock, that is cardiac tamponade, that requires the pericardiocentesis. In case of pediatrics, it's better or desirable that you check for auscultation every now and then, because then you can appreciate muffled heart sounds. Otherwise, in the ECG, you can see electrical alternance, not necessarily seen in pediatrics, but the ST changes are there. The concavity of ST waves that we read, na, the I think difference from myocardial infarction from pericardial uh, pericardial tamponade is there. So those things, but electrical alternance, if found, is a very ominous sign. That is alternating amplitudes of the R waves is seen. Then you have to go for a pericardiocentesis. So under uh, USG guidance or echo guidance, you just put your probe over the xiphisternum, and then you go for that xiphisternal view of the heart. You can appreciate that through echo. If you have done it, you can very well relate. And then you just below the probe, someone is holding the probe, obviously you are going to insert the needle, and under USG guidance you aspirate out the fluid or the blood. Okay, so then obviously you can jolly well resolve it. But what is important is there is a backstride. So there is hypotension, but jugular veins are going to be distended and muffled heart sound, as I was telling time and again. And very important is in pneumothorax, other than the X-ray, the first thing that should alert you is, I think pneumothorax is fairly easy to diagnose clinically. You don't need an X-ray. You will just look for bilateral equal breath sounds are present or not. If there is not, there is one side you are not hearing anything during resuscitation, be very alert. It's a pneumothorax or it's a hemothorax also maybe. So, but to err on the side of caution, think of it as a pneumothorax first. Give the ICD or give the needle. If not ICD, if you give the needle, you can actually save some lives. Okay. So the pneumothorax doesn't have a muffled heart sound, but the uh, cardiac tamponade will have, as is very easily explainable. So next slide, please. Okay. So toxins, very important because of pediatrics is we have actually seen many heartbreaking things, like because children are natural explorers and people in their homes are not always very careful about keeping toxic things out of their reach. I have seen so many bad things. Very latest was a turpentine oil poisoning. It was a perfectly well child. The child was playing in the house and in some relative's house actually, and they had kept in a water bottle that turpentine oil. Okay, it's used for painting and stuff, the household paintings and those things. So it's a very irritant and very bad thing basically. And after the child had taken it, the what the parents or the relatives did was something even worse. They made the child vomit it out. Never should be done in case of any kind of substance which is very easy to vaporize. So during this vomiting out, actually what happened, the child aspirated the things further. And when the child came to us, there was already respiratory distress. We first gave an IV, then IV could not work. We had to intubate the child, and ultimately we lost the child. So it has no antidotes. There is only supportive measures can be given. We tried everything. One more thing children usually also accidentally take is kerosene. Kerosene is also is notorious to cause a chemical pneumonitis. Okay, so all those things, there are no antidotes, but I have seen poisonings happen. So poisonings are something you should keep in mind. Also, OP poisoning, you have to give your antidotes promptly. If there is time, you give pralidoxime. Otherwise, you atropinize the child entirely. So we have seen two in the same day only. We had two patients with OP poisoning. One patient was just after charging pyridoxine and after 1 or 2 hours of infusion of your atropine, the child was perfectly okay. The child opened the eyes, we extubated the child promptly, and the next child, the second child, took some time to come out of it. But if antidote is administered in time, it's very well done. Also, I must say one thing in toxins, because we are in India, envenomation is something you must keep in mind. This is something of a story from my internship, which prompted me to take up pediatrics, because this is one of the main reasons, because there was a child that came in this sort of a comatose situation only. So after giving those oxygen and stuff, because I was an intern, but we were taking history, and what we heard was that the child was lying on the floor with his mother, and both of them were comatose the next morning. So I just ran to my senior and told him that this child might be a case of a neurotoxic snake bite, because in our UG college, Bakuda, it's very notorious to have those crate snakes. Okay, they don't give a bite mark, and it's a very notorious neurotoxic venom. So instantly the child was taken to PICU, was electively intubated, and the child was, after a few days, okay. The mother was unfortunately succumbing to the thing, but the child we could save. So in my internship, only through this I could actually see that just by keeping your eyes open, and I was fairly decent in managing such a thing. If I had not had this intuition to inform my senior that this might be a neurotoxic snake bite, the child would have also succumbed. So, in case of a droopy eyelid or a ptosis or any kind of jerky respirations, okay, if there is a bite mark or not, these kind of things of envenomation must be kept into mind. Okay, so next. Okay, thrombosis, I think I told now. It's a last thing that you come across. Usually H&T's correction, all those other things are picked up earlier, and if only after correcting and looking for all those things they are not there, you go for a CT angio, or you try to go for a ECG again and get them read by a cardiologist, because pulmonary embolism or coronary thrombosis in a child I have not seen practically. Okay, so next please. Okay, so in case of trauma, this goes into the domain of ATLS, but what they extra teach you in ATLS is, firstly, the cervical spine should be stabilized. So all those over enthusiastic head tilt and chin lift things you don't do in a trauma patient, you only do the jaw thrust. Okay. And there is also a thing called manual inline stabilization. So all those things are there, but it's better that an ATLS trained person tells you all those. But ATLS is fairly similar to ALS. Only the I think some modalities of intervention are different. And because I'm not practically trained in ATLS, although I plan on doing it soon in future, but I'm not trained in it. But from theoretical perspective, it's fairly similar. Only adjunct what I could decipher was the cervical spine protection and stabilization. That was very important. Okay, next. Yes, so here comes my role as a pediatrician or an ICU junkie like me, that what you do after you have successfully gotten an ROSC, you have brought the child back from a cardiac arrest. So that is also a very important thing, because in pediatrics, post cardiac arrest patients often have a high percentage of neurodeficits in their later on life, because na, the brain is very much sensitive to hypoxia. If there is more than 30 seconds of hypoxia to the brain, parts of it starts dying. And also in case of post cardiac arrest, what occurs is you have a hypoxia. There was some hypoxia, there was some tissue necrosis, tissue death was there. But after you have achieved the ROSC, the circulation is back. Now what happens is, it's very dangerous. It's called a reperfusion injury. So the parts of the brain that are called the penumbra, the parts surrounding the necrosed area, those penumbra things get calcium influx, and they then start again necrosing, and those things are very bad. So it's a molecular level of catastrophe that is happening in a post cardiac arrest brain, which is why You have to optimize oxygenation. Now oxygen is a drug. Now you cannot go and give 100% oxygen jolly well to everyone. You should just taper it. If the patient needs oxygen to maintain a saturation above 95%, then you give, otherwise don't. Maintain perfusion, obviously. A minimum of mean arterial pressure is to be maintained through uh, keep the CPP, cerebral perfusion pressure, at the right levels. So you have to take care of that. You give your inotropes now, you taper them, you add or minus them, you give your bolus if required, and you control the temperature. Here, one thing has been emphasized, that is, you must avoid hyperthermia in a post cardiac arrest patient, not hypothermia. In a post cardiac arrest, it has been seen that hyperthermia is much more dangerous. Okay. Hyperthermia is actually associated with increased mortality in a post cardiac arrest patient. So, what you do is prevent hyperthermia. You give paracetamol, you give cooling blankets, cooling solutions to the patient, and maintain the optimum temperature. So, neurological care prevents secondary brain injury. As I was saying, secondary brain injury means this reperfusion injury, as I was explaining. So prevent means you have to be prompt in treating an arrest. The more quick you are in managing an arrest, the more early you find ROSC, there is less chance of the primary damage of necrosis or death, right? So the less chance of the secondary damage. So that is why prevention is better than cure. And yes, post cardiac arrest there can be seizures, so you are going to go for anti-seizure medications. And these drug doses is what we already came across. So next, I think we are almost done. Yes. Okay. So this I want you guys to respond in each case. First, we are going to go for case one. So a mother has found a 4-month-old unresponsive at home. What they have found? There is no response, there is no breathing, but she has found the pulse is 70 per minute. Okay. So what is the next step? If someone can just answer A, B, C, or D. Uh, yes, yes, okay. I'm very happy you guys have understood the assignment. So, because the pulse is more than 70, it's not a RS scenario. We're not going to start chest compressions, but the patient is not breathing. So, go for rescue breaths. Right, very old. Very well done. Next, case two. There is a 2-year-old child. Okay. It's a near drowning situation. Okay, so now near drowning is a term that we avoid now. So we can say drowning or dry drowning. Okay, there are two type of drownings, wet and dry. So again, too much elaboration perhaps. So near drowning means the child was not perhaps inhaled the water into the lungs. Okay. Now, after coming to the emergency, I am hoping the child is brought to us. Okay. Let's take it as an ALS scenario only. We have found that the pulse is 50 per minute. Be very alert. There is poor perfusion, child is not breathing. So now what you do? Okay, okay, very well done. I think you guys responded C for this also. So actually this is a cardiac arrest scenario, less than 60 pulse rate and not breathing. So it's an arrest scenario. You start chest compression, you will go for all those things that we do in an arrest. You go for 2 minutes of everything. And if someone can tell me what is the ventilation to compression ratio in this scenario, any one of you? The ventilation to compression ratio. 2-year-old 15 is to 2. Yes, okay. You are assuming there are two people, then you are going to do 15 is to 2. Fine, I'm okay with it. If you are, yes, Kumud Gupta, you are right only. Dr. Kumud, thank you. So if you are a single person, you are going to give 30 compressions to rescue breaths. Very fine. Well done. Okay, thank you, Twinkle. You are also right. If you are a single person, 30 is to 2, two people, 15 is to 2. There should not be any confusion in that. Okay. Now, third one. Now, a 10-year-old collapses during a game in a school. Okay, it's not a hospital. It's a BLS scenario. There is no pulse, no breathing. So I am assuming that someone has already started the CPR, and after that, the AED has actually given ventricular fibrillation. What is the not the first treatment? Actually, the question should be the next treatment. Okay, 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 okay. Okay, so Dr. Ajit Kumar and Dr. Gladys, you guys are right. This is a scenario of what? It's a VFib. It's a shockable rhythm. It's a VFib. Okay. What we told. Okay. Dr. Imjim, if you can go back to the shockable rhythm page once, please. A bit previous. Yes. See, VF means ventricular fibrillation. So it was a shockable rhythm. Okay, so you're going to give shock first. So I think we are done. I think we are done with everything. So
Thank you. Thank you, Dr.
yeah.
Esha, for this wonderful webinar. I think the main punchline that I will be trying to draw from this is, do not go into an arrest as a doctor before the patient has gone into an arrest, because I think majority of the times, me having had whatever exposure to critical care that is, I have always found this, that it is very important to uh, make this a muscle memory. And one of the best ways of doing it, which I have figured out, it's my personal choice. I mean, again, different ways can work for different people. That is, what I used to do often when I was in my, first year, especially in the first few months of my residency in critical care postings. One of the major things that I do is, while bathing or maybe while getting up from sleep, especially in times when I'm supposedly supposed to be relaxed, like, I'm taking a bath or maybe taking my lunch, I used to deliberately create a scenario in my mind to check my response, my internal response. And I believe once you have crossed that hurdle where it becomes a muscle memory, half of your problem is solved. And as Dr. Esha says that, and as one of our favorite teachers who taught us used to say, that common sense is the most uncommon thing in common man. It is important that we maintain our common sense. It is important that we see what we are seeing. I mean, we see the patient and not just the monitor, because the monitor is just an indefinite or temporary reflection of what the patient is going to give. It is important that we identify what a tension pneumothorax looks like, so that we do not have an arrest before the patient goes into arrest. And one thing which I would be just liking to add on to what Dr. Esha says is, there is often this concept about mouth to mouth breathing. So I do not know if how many of you are aware as to why mouth to mouth breathing is considered as a rescue method. I repeat, it is not a definitive method. It is a rescue method during BLS until your medical help comes. And one of the reasons is that normally when we are breathing in normal atmospheric air, the FiO2 that we are taking, it is around 21%. And the body actually uses almost 4 to 5% of the FiO2 that we breathe in, which means we are still left with 16 to 17% of FiO2, which is actually the FiO2 that we are delivering in an expired breath. That is what we are giving in a mouth to mouth breathing. So yes, it is not a definitive process, but it is definitely a method in which the lungs and the alveoli, to be more honest, are kept open, so that adequate ventilation uh, is maintained unless the corrective steps, or until the corrective steps arise. This is one thing. Another thing that Dr. Esha pointed out so beautifully, I mean, taking a 2-hour class on BLS and ACLS is not an easy job. And I think she has covered almost everything to the most, I mean, to its finest nuances. But there's one thing which I feel that I should just add in the end, that there might be a confusion when you go through this PDF, that whenever there is a VT with a pulse, the management is different from a VT without a pulse. The reason that you will give a synchronized cardioversion when there is a VT with a pulse is because a VT with a pulse signifies that the cardiac output is still maintained. in the setting of a cardiac output still maintained, it is very important to synchronize at the peak of the R wave and give a cardioversion. Whereas whenever there is a VT without a pulse, the cardiac output has already started to compromise, which is why at that point of time, giving defibrillation is the best management. So thank you, Dr. Esha. Once again, I would love the forum to be open for questions. Uh, yeah, it is 2 hours and 30 minutes. I absolutely understand, but trust me, you do not realize the value of something when you are getting it in the current moment. But trust me, the ones who have stayed back and the ones who have paid absolute attention, I promise you, if you are going to take up residency in pediatrics at some point of time, or even if you don't do residency in pediatrics, if you are getting a situation like this in the aeroplane or maybe in the trains or in the roads at some point of time, today's session is going to be massively important and massively vital. It will at least trigger your cortex to think more and to be calmer. And that is the note in which I will end my vote of thanks to Dr. Esha. A huge shout out to her because I know Dr. Esha as someone who you are just seeing so prolific and so eloquent in what she is expressing. So I am glad that you have put in this effort. And I mean, this is nothing new for me because I have been seeing you for quite, as you said, a decade now. But I'm so glad that almost an audience of almost one lecture class, which is close to almost 100 audiences, were there till a significant point of time. And to the ones who have stayed back, immense shout out and thank you to all of you. I'd be wanting you to be free to ask any questions, although Dr. Esha has, answered quite a lot of them during the course of our conversations. But if there's any further question, we can keep this window open for maybe another couple of minutes, and
One more
we
thing
can
I must say, the Dr.
exactly. So,
Rimjin deserves a huge applause because Dr. Rimjin actually
absolutely,
enabled us to
absolutely,
do this because I was having so many technical glitches. So just the Friday the 13th phenomena was continuing with me.
absolutely, and
So
for people who are new to this platform or are who haven't been very much in touch with Mediversal webinars, this is one comment from Dr. Sakshi, I think, if I'm not pronouncing your name wrongly, that it is an MD level class in certificate class. Absolutely correct. You basically got an entire training of what is taught in an MD level. So that is why I said that you do not know the worth of what you have learned today. Maybe at some point of time, I believe life gives you enough a chance. I believe not to the patient. I wish well for all the babies, but I believe life. I hope then pray that life gives you a chance to be doing the right things at the right point of time. And you can remember Dr. Esha at that point of time because she is definitely one who has tried to light up that amount of interest in you. And Dr. Rimjim, of course, I mean, I'm mentioning your name in the end because I think it is the end that stays. And Dr.
mm,
Rimjim was so
yes,
spontaneously ready to do the slides. In fact, although the
she was the
slides and the
lifesaver.
pictures,
She actually
yes, she has been a lifesaver.
came to the call to
Absolutely.
the help and started the CPR
Yes.
in this thing
I,
and
I
moving
think I
fast.
think I think basic life support. Truly, I think the
Was
award of the
done
day
by
should
her.
go to, yes, should go to Dr. Rimjim. And yes,
Yes.
we will be looking
Thank
forward
you
to
so much.
conduct more sessions. There is one update that I therefore definitely want to give. There is a webinar that I'm conducting on the 27th of this month, which is on ventilator mechanics for adults. So everyone who has been attending this session and or at some point of time have done their emergency medicine postings or maybe their critical care postings or are looking forward to do critical care, ventilator is one of the ghosts that I always say that it's important to tame the ghost before the ghost tames you. So it is my humble request that you all join that, and I will try to make it as interesting, if not better, than what Dr. Esha has already done. And I will try to make it something which does not haunt you at all in the subsequent nights of your life. So thank you to each one of you, and lots of love. And I hope you
Thank
all stay well. You
thank
hope
you.
you all do well. And I give it to Vijay sir to conclude the meeting. Yeah.
Thank you. Thank you, doctor. Thank you so much. Meanwhile, we wait for the Q&A sessions on the chat box. I am dropping the certificate link for you guys to fill the form and to get the certificate. One small information, if you can, while you fill in the form, please do submit it properly so that you will get your certificate directly to your inbox. If not inbox, sometimes it might go and fall in the spam folder. Please do check on the spam folder to get your certificates. The Yeah, the chat link, the certificate link is in the chat box. Meanwhile, anyone can ask any questions. Like doctor said, We might not have one, but we would really love to answer any of your questions. The doctors here, the whole panel is here basically. Dr. Navanil, Dr. Esha, and Dr. Rimjim. So you can question any doubts. You can just drop the question in the chat box. Twinkle says, really, we had more sessions. We need more. Twinkle, you have been one of the regular candidate to us, regular student, and we will guarantee you that these sessions will always be in track. No matter what, the sessions will always, we will bring beautiful sessions such. Uh, any questions you can drop in. I would again drop the chat link. Sorry, not chat link. Sorry, certificate link. I would also drop our social media channels because we have a beautiful sessions planned up for the month of March. The calendar is already been announced on our social media channel. Please do go and check our channels to get more info on all our upcoming sessions. Like doctor said, we Dr. Navanil session is there, and we have few more session lined up for you all.
Okay,
And
so
and
I
and
think I
before
just want to say a few things just
yeah,
before.
just before Esha takes over, I will want all of you to wish her all the best, because she's going to begin her super specialty very soon. And this is one of the feats which she doesn't talk about much. And being as humble as she is, I know how difficult it is to be through the gruesome phase of MD pediatrics that she has been through. Gruesome, I think, is the least word that I can use. And to still be getting into a super specialty this soon, I think it is a wonderful feat. So trust me, for the ones who are, I think Mediversal has been planning up some workshops on intubation, pediatric intubations, and we get so many queries from doctors who are wanting to know how to intubate in the hands-on skills. So I think Dr. Esha is one of the finest people that we have here for pediatric intubation, and I want you all to wish her a very very good super specialty life as well. So yeah, Esha, you can take over.
Okay, so only just give me a minute. Okay, so sorry, sir. Yes. Only thing I'd be very glad is that I'd love to take up more classes wherever I am, whatever I do. Fingers crossed for my new residency because I am hoping that I'll be coming across more such scenarios. So just revisiting old memories and scenarios was actually helpful much more for me. And secondly is I think okay, thank you. So there are not much queries. And I'd really be glad if you guys take up media because it's something I'm very passionate about, as you hopefully can understand. So yeah, and thank you, Nohol. You are also a lifesaver in many ways that you know. So I'm not telling much about all this right now. So just to tell you all, 90% of the preparation of this webinar, at least the slides, were made by Dr. Naupani because I was in a fix and he actually very generously helped me out. And same for Dr. Rimjim also. So thank you so much. And I think uh, we are uh, over right now. So is it?
Yes, doctor. Thank you. Behalf of
Okay.
Mediversal Academy, I would extend our gratitude to you for joining this session and having the long session for our candidates. As always, thank you, Dr. Navanil, and really thanks to Dr. Rimjim for supporting the session today. We are. Thank you. Good night.
Thank
Okay.
you, thank you
Good
so
night.
much.
More 5 more minutes. If anyone wants the social certification link, I have dropped it. I'll be here for 2 more minutes. But yeah, the session is, we can end the session, and good night for all.
Thank you, good night everyone. Yeah.